Distinguished delegates, professors, and my dear colleagues, I, Dr. Vindhya Malasani, attending consultant in Sarvodaya Hospital, am delighted to welcome all of you to Crown Plaza for Theranos Conclave 2022 under aegis of Society of Nuclear Medicine Northern Chapter powered by Sarvodaya Healthcare. It gives me immense pleasure to be standing in front of all the most esteemed personalities who have won accolades and done so much to nuclear medicine as a field, which led to the position we are right now in India and globally. The Society of Nuclear Medicine India was founded in 1967 with the aim to promote, encourage, and help the development and advancements of nuclear medicine as a specialty in India. All the way through over and above 50 years, the Society, through annual conferences, periodic regional meetings, and through its academic wings, have been providing a great platform to our members for exchange of ideas and sharing their experiences. Today, on behalf of SNM India Northern Chapter, I take the privilege of welcoming all of you to this first physical conference being held after a long gap of almost 6 years. Now we would like to present a short infra glimpse of Sarvodaya Healthcare. The theme for today's program is Theranostics in Nuclear Medicine for Neuroendocrine Tumors and Carcinoma Prostate Patients, where the experts are going to discuss about their experiences and challenges in treating these patients with special focus on F-DOPA neuropet imaging and movement disorders. I consider it as an honor to welcome Dr. R.K. Gupta sir, the Chairman Sarvodaya Healthcare. I am glad to invite Dr. Vibhuranjan Gupta sir, Group Medical Director, Sarvodaya Healthcare, on the dais. It's my privilege to invite Dr. Pankaj Dukkal sir, President SNMI Northern Chapter, Principal Director and Head Nuclear Medicine PET-CT, Max Super Specialty Hospital, Saket. With equal pleasure, I invite Dr. Gaurav Mittal, Secretary, SNMI Northern Chapter, Scientist F and Joint Director, Division of Radiology, Nuclear and Imaging Sciences in MAS DRDO. The next dignitary to honor us with his presence is Dr. Baldinger Singh Sir, Dean, Indian Medical College, Nuclear Medicine and Professor, Postgraduate Institute of Medical Education and Research, Chandigarh. He is also past President, SNM India. I request Dr. Ankit Vats, Secretary SNMI, Nuclear Medicine Physicist in Department of Nuclear Medicine and PET-CT, PGI MER Chandigarh to grace the stage. Next, we look forward to the presence of our Organizing Secretary, Dr. Swagat Dash, HOD, Nuclear Medicine, Sarvodaya Healthcare, and Treasurer, SNMI, Northern Chapter, on the stage. I would now request Dr. R.K. Gupta, sir, to say a few words.
Good evening, friends. I welcome all the dignitaries coming from various walks of life and specialties to this update session on nuclear medicine. She just told me that the Society for Nuclear Medicine was formed somewhere in 1967. So I did my graduation from 1980 or 79 to 88. At that time, it was very difficult to hear about the nuclear medicine. But as the IT has evolved, so has the imaging evolved, and so has the nuclear medicine evolved. Today, it is coming up as a very upcoming branch, and it forms the backbone or the basis of working for any oncologist or anybody who's going to do anything with the cancer. Now the term says Theranostics, which is a combination of diagnostics and therapeutics. So nuclear medicine is now going to diagnostics, from diagnostics to therapeutics. I find myself as a lay person standing over before you, all the august gathering, all the experts from various field of nuclear medicines. But what I gather is that people from various fields, from somebody from the radiotherapy, somebody from radiology, somebody primarily from the nuclear medicine, they have converged into the evolving or evolution of the nuclear medicine. I wish this conference a huge success, and I'm very sure next 2.5 or 3 hours are going to enrich the knowledge of all the budding nuclear medicine specialists, and the seniors from the field will be sharing their ideas and experiences with all the people around, including lay people like me. Thank you very much. Enjoy the conference.
Thank you, sir. I would now request all the delegates on the dais to gather near the rear for inauguration. Before we kickstart the scientific program, I would like to express our gratitude on behalf of entire organization team to all of you who sincerely contributed to this event in order to make it possible. This could not have been possible without the support of each and everyone present here. Now I would request Dr. Jaspiya Bal ma'am, Consultant, Department of Nuclear Medicine and PET-CT, Max Super Speciality Hospital, Saket, to take over the dais. To take it forward.
Good evening, everyone. It's an honor to take over the stage now, and I welcome you all to one of its kind multimodality academic feast. Today we are all gathered here. We have some eminent faculties from various fields. We are here to gather to discuss ideas, impart knowledge. We inspire each other in the ways so that we walk out better with the management, and we are able to make our day-to-day decisions and handle complications. So without wasting much time, let's start with our first panel. Neurology. So our first panel is on neurology. With the current advancements in radiotracer developments and technical advancements in molecular brain imaging, we expect neuroimaging to transform into a routine clinical tool. To discuss this, we have a very eminent faculties to discuss the role of F-DOPA neuropet in movement disorders. I would like to invite the panelists. Our first panelist, Dr. P.N. Ranjan. He's a senior consultant, neurologist, academic advisor, Institute of Neurosciences, Indraprastha Apollo Hospital, New Delhi. Our next panelist, Dr. Madhvi Tripathi, Additional Professor, Department of Nuclear Medicine, All India Institute of Medical Sciences, New Delhi. Dr. Ritu Jha, she is a senior consultant and head of the Department Neurology, Sarvodaya Hospitals and Research Center, Faridabad. Dr. Sushma Sharma, she is Director Neurology, Metro Super Speciality Hospital, Faridabad. Our next panelist, Dr. Sriram Rajan. Still not here, I guess. Dr. Neha Kapoor. She is Senior Consultant and Head of Unit at Asian Institute of Medical Sciences, Faridabad. Dr. Ashish Gambhir is Consultant Nuclear Medicine and Molecular Imaging, Narula Diagnostic Center, Rohtak. To moderate the session, I would like to invite Dr. Ritu Verma. She is a Senior Consultant, Head of the Department Nuclear Medicine at Mahajan Imaging Center, Sir Gangaram Hospital. Over to you, ma'am.
Thank you very much, and good evening, my dear friends, seniors, and colleagues. And at the outset, I would like to thank Dr. Swagat for giving us this opportunity to be here and interact with all of you. And he has managed to gather a group of eminent panelists. And without wasting time, we would start the program. Our radiologist is not yet here, so we'll see whenever he comes, he can put his input. So the first thing which comes to mind when we are evaluating someone with movement disorder is the question arises when to investigate in a patient with movement disorder, how to investigate, and how much to investigate. So we would like to our eminent neurologists to answer most of these questions, and we'll provide our inputs as we go on. So to begin with, our radiologist is here, so Dr. Sriram Rajan. So with your blessing, sir, Dr. Ranjan, sir, we would like to ask first question to you. as in the order of management in a patient with movement disorder, which imaging modality do you choose first and why, sir? Sir, they'll give you a mic there.
Good evening, Hello. Hello, good evening, everybody. Thank you, Dr. Swagat. Thank you, Dr. Ritu, to ask me to be coming here today. And indirectly, what Dr. Ritu Verma wants to know, that how do you go about investigating a movement disorder? As you all know, that the second most common movement disorder is Parkinson's disease. Now, does every patient who has a Parkinson's disease, a typical Parkinson's disease, requires to be investigated? How I look at it is that if I have a Parkinson's disease, which is not typical, but is an atypical Parkinson's disease, this gentleman definitely needs to be investigated further. What investigation we would do, I would come to that further. Now, the question is that what looks like a Parkinson's disease disorder one and a half years down the line. Now, the question behaves like a Parkinson's, that what looks of Parkinson's syndrome. And obviously we all know down the line. Now, the question behaves like a Parkinson's, that what looks of Parkinson's syndrome. They respond very all down the line. Now, the question behaves like a Parkinson's, that is what becomes a syndrome. They respond very all down the line. Now, the question behaves like a Parkinson's, that is what becomes a syndrome. They respond very all down the line. Or you are dealing with a degenerative disorder presented like a Parkinson's disease. What do you do? Or you are dealing with a degenerative disorder presented like a Parkinson's disease. What do you do? Or you are dealing with a sexual degenerative disorder presented like a Parkinson's disease. Imaging was made. Or emphasize with a sexual degenerative disorder presented like a Parkinson's disease. Imaging was made. Or emphasize with a sexual degenerative disorder presented like a Parkinson's disease. Imaging was made. Or emphasize with a sexual degenerative disorder presented like a Parkinson's disease. Imaging was made. Or emphasize with a sexual degenerative disorder presented like a Parkinson's disease. Comes to imaging was made. Or emphasize with a sexual These are the non-motor manifestations of Parkinson's disease. At this stage, yes, I use imaging. And I must tell you that I have been exposed to SPECT, PET-CT, and now PET-MR. So what I do is a hybrid imaging. What I mean by a hybrid imaging is that I would do a Doppler scan, I would do a FTG, and I would do obviously an MRI to come to this conclusion whether we are dealing with what. This also becomes important in centers which underdo DBS. DBS, as you all know, is deep brain stimulation, which is done for patients of Parkinson's disease. So if you go and start doing DBS on a patient who has a Parkinson's plus, you'll be going to do gross wrong and doing much worse to the patient. So I think imaging has gone a long way. And imaging is going a long way. And hybrid imaging, to my mind, seems to be the present thing which we should all be doing.
Thank you very much, sir. So, the thing is, we want to discuss next what is the role of MRI in movement disorders. We all know that MRI is essentially used to exclude causes of secondary Parkinsonism. So I would like to request Dr. Sriram to tell me a few causes for secondary Parkinsonism which could be picked up on MRI, and also the standard patterns that is described in the literature about the tiger's eye sign and the hummingbird sign. These appear very late in the process of neurodegeneration. Is there any particular pattern which has emerged now and which helps in early pickup of disease? So I would request Dr. Sriram Rajan to discuss the role of MR in movement disorders.
Thank you. So what we are familiar with, I'm just showing a bunch of images. The image in the top left-hand corner is structural imaging. So we're basically talking about either reduced volume, substantia nigra. When we're talking about PSP, we are talking about predominant midbrain atrophy. There are a series of assessments of the volume. So the most insensitive or something which might miss very early cases is just looking at AP dimensions of the midbrain, or at looking at Oba's ratio, which is midbrain to pons ratio. There are other things like MRPI, the MR Parkinsonism Index, and MRPI 2.0, which tries to assess structural changes. Now, the other interesting kinds of imaging which can be done, one is melanin sensitive. These are very heavily T1 weighted scans, and they are good for assessment of non-heme iron. I'll just show in subsequent one or two images that, so this is basically what we tend to see with SWAN images or susceptibility images. So normally there is a layer in the substantia nigra which is in the pars compacta, and that tends to show brightish signal on the susceptibility weighted images. So you get an image which looks like a swallowtail. It's known as a swallowtail sign. Earlier there was a lot of promise on this. Now this has a very good negative predictive value. What this means is that if a patient comes in with, say, essential tremors, and we do a SWAN, high resolution SWAN image, and if we see the normal swallowtail, then the chances of it being Parkinsonism is very less. None of these tests are 100%. You will still have some exceptions. Many of these patients, we have in the literature also, we have cases in which you can have this kind of an image. This is on 7 Tesla, this is from the literature. In Parkinsonism, basically the ventrolateral aspect of substantia nigra is the thing which gets involved, and instead of a smooth convex outline, you can see an irregular outline, what we're seeing over here. Can we go back to the prior images, like one more, back. So the other kind of stuff which we can do is, now we've done melanin sensitive or magnetization transfer images at our center. They are very good. They assess. Unfortunately, they don't assess too much on the pars compacta. They look at the pars reticulata overlapping on the pars compacta. The other things on the bottom is diffusion imaging and tractography. These are helpful in those cases where there is a clinical picture which might look like Parkinsonism or a mixed picture, and you want to find out. So if you do a DTI or tractography, you'll find that the tracts are not actually going through that area. There's a reduced probability of connection. There's something known as resting state MRI. fMRI is something which is slightly more esoteric because it requires a lot more of processing and statistical mapping, which only few centers can do. So we do have neuroscientists who work on this at our center. So if we get cases, we do try to do this. So this actually looks at functional connectivity between the striatum and the substantia nigra. Can we go next? We'll just quickly, next. So this is basically just showing neuromelanin versus nigrosome. Those are our images. That's the image on the top left shows the swallowtail of the normal substantia nigra, and the image on the top right shows neuromelanin, which is a bright structure which you can see at this expected location. Here you can make out that the neuromelanin and the T2 star, there is a little bit of a non-overlap. Next, please. Last of all, there has been some debate about whether the swallowtail actually corresponds to nigrosome 1. So that central image which you see, which shows that red and blue, so what that actually shows is that the swallowtail is what we are seeing just in the blue, whereas the nigrosome 1 layer is actually a little bit more, and it tends to be more darker. So, which is why probably this whole thing is a little bit more complex. Statistically, we are finding that there are cases where the swallowtail is gone. We can say that is Parkinsonism. But like I said, there are some cases where you can see a swallowtail, the patient continues to have Parkinsonism and does respond to deep brain stimulation. So there is a little bit of heterogeneity. MR does help, but there is a role of nuclear medicine which we'll be coming to.
So is there a future role of tractography, as in we all know that Parkinson's disease and most of the degenerative Parkinsonian disorder, they affect the abnormal or the indirect basal ganglionic pathways. So can we in future comment upon whether the direct pathway is affected or the indirect pathway is affected, or whether there is a reduction in the nigrostriatal fibers in future?
So this is still happening as in research going into clinical work. We have forms of sequences where we've got our team at the AI research who are basically doing that. They're looking at fiber density, like in the striatonigral pathway, and trying to differentiate that versus, like normal volunteers versus cases who have, Parkinsonism or Parkinsonism plus. Incidentally, the swallowtail sign, one question is that, is it only there in Parkinsonism or is it there on Parkinsonism plus also? So in PSP, strangely, you can have extreme loss of the swallowtail, which is why, because its nigrostriatal degeneration is occurring in PSP also. So it's not that it's going to be great in differentiating one from the other unless you have the clinical, which is very important. But you can exclude it. Like if it's present,
as you said, there is a good negative predictive value. So thank you very much, Dr. Sriram. Moving on to our next coming to our biomarker, that is F-DOPA. So first we'd like to ask our clinician, Dr. Ritu, who exactly are the class of patients? Can you elaborate a little more on that, the class of patients where you would like to investigate, and what exactly do you want from that investigation? And who are the patients who need to be investigated by dopaminergic imaging?
Okay. So first of all, the classical Parkinson's disease patient, as sir has already mentioned, that most of the patients, first of all, we diagnose clinically. Those patients who are diagnosed clinically, we really do not need to investigate them further. We do not need to investigate them too much, except those patients in whom there are some atypical features. Now, what are those atypical features are? Suppose a patient with Parkinsonism who has tremors, but less of bradykinesia and rigidity. So we are not sure whether they are falling into the category of essential tremors or they are Parkinsonism. So, and they are very bothered by the tremors, and we do not know if DBS is going to help them and whether they are ET or whether they are Parkinsonism. So first category falls into them, because then our F-DOPA can differentiate between whether there is a nigrostriatal degeneration or there is not degeneration. So one category is that. Then there are atypical PDs in which we are getting early falls in the so-called PD patients. We were thinking that the patient was a PD, but then we start getting early falls. Then there are patients who are presenting with autonomic features, or they start developing cerebellar symptoms, or those patients who are showing little poor response to levodopa or the dopamine agonist, or those who are showing some amount of hypersensitivity to dopamine agonist, which we are giving. So, and showing some amount of cognitive decline along with the PD, early cognitive decline in the PD patients. So those are the patients in whom we start suspecting that there is something besides Parkinsonism. And we start calling them Parkinson's, atypical Parkinson's, or Parkinson's plus syndromes, meaning that there is something beyond Parkinson's, and then we need to investigate them further to categorize them which Parkinsonism plus syndrome they fall into. Like we have MSA, we have PSPs, corticobasal degeneration, dementia with Lewy bodies. These are the primary 4 categories that we look for. So to which 4 categories we want to categorize the patient. Or it's just a simple Parkinson's disease patient with poor levodopa responsiveness.
Okay, thank you very much. So now that we have established that dopaminergic imaging done with F-DOPA establishes degenerative striatonigral disease, that is degenerative Parkinsonism. And I would like to ask Dr. Madhvi, since she has such a great experience with doing both FDG and F-DOPA, I would like her to ask her whether she would like to do F-DOPA in all patients and FDG also in all patients, or which are the group of patients where she would like to do FDG also, or whether both of them should be done in all patients. What's your opinion?
Thank you, Ritu. Dopaminergic imaging primarily we would like to do when we want to, when there is a doubt whether it is neurodegenerative Parkinsonism or not. And when the suspicion is, when the clinician is sure that it is Parkinsonism, but they're not sure whether it's typical or atypical and want to distinguish the two, that is where we would prefer to do FDG. Again, to distinguish DLB and AD, the dopaminergic imaging is preferred, and FDG also can be done as a supportive marker. So primarily dopaminergic imaging would be to differentiate neurodegeneration versus non-neurodegenerative Parkinson. FDG would be for establishing the atypical variants. And I usually prefer not to do both of them together in each patient unless there is that clinical question. So unless it's clearly indicated that the clinician wants to differentiate Parkinson's from atypical, those are the only cases I would go for FDG.
Yes, sir. But then what?
So, what do you mean by saying you don't like to do both the thing on the same day?
No, like depending on the indication, we would like to do dopaminergic imaging where the clinician's question is that is it Parkinson's or not? Is it neurodegenerative Parkinson's? Be it IPD, be it atypical, be it DLB.
Yeah.
The entire spectrum. For that, we would like to do dopaminergic imaging. But where your question is, this patient is having recurrent falls, this patient has a gaze palsy, this patient is not responding to Syndopa, I have to take up the patient for DBS. We want to establish whether the metabolic pattern looks like atypical, then we would go in for the FDG imaging.
Yeah, especially in Parkinson's, after all, 20% of patients of Parkinson's disease, primary Parkinson's disease, are associated with dementia. 20% of typical Parkinson's has dementia. So obviously you also want to distinguish whether this dementia is Parkinson's-induced dementia, or is it a Lewy body dementia, or is it Alzheimer's dementia. So in this situation, you would agree that FDG would be practically mandatory in every patient.
Yeah.
Thank you, sir.
Yeah.
Thank you, sir. To answer that question, usually Dr. Madhi wants to say is in very young patients like early onset YOPD patients, young onset Parkinson's disease, or where the clinical question is just ET versus PD, where the patient has no other symptoms, if it's a monosymptomatic tremor, maybe doing an F-DOPA alone would suffice. Or where the clinical diagnosis is so strong that this is a Parkinson, it has been a Parkinson for the past 5 years. If the person wants to know whether there is a dementia associated with it or any other new finding which is not a part of the disease process has developed, maybe an FDG PET scan can be asked for. And whenever there is this possibility that it's an atypical Parkinson's disease, FDG PET should always be asked for. So next we would like to ask Dr. Gambhir, Dr. Ashish, as to do you find any difference between F-DOPA? Are there any advantages in doing F-DOPA over TRODAT that we have been doing traditionally for the past so many years, and vice versa?
Ma'am, on the onset, F-DOPA is a PET tracer, so there are obvious advantages of resolution and possibility of semi-quantification. And apart from that, DOPA is easier to do. You have to inject, wait for 1 hour, 2 hours, and then do. For TRODAT, you have to wait for 3 hours. So apart from the logistical aspect, DOPA is beneficial also in terms that it is a more pathological representation of dopamine availability in the neurons. If we come to TRODAT, TRODAT is also good, but TRODAT little overestimates the disease. And the only advantage of TRODAT is in very early stages of Parkinson's, where the DOPA may be normal because of overproduction of dopamine and over activation of normal DAT receptors, while the TRODAT may still show reduced uptake. So in early stages of Parkinson's, Trodat may be beneficial compared to Dopa.
Thank you, Dr. Ashish. I would like to go back to Dr. Madhvi and ask, have you ever seen any patient where the Trodat was abnormal and Dopa was normal?
Trodat was abnormal and Dopa was normal.
As it says in the literature that Trodat is overtly sensitive. It sometimes overestimates the disease. So in very early disease, the Dopa may be abnormal, which Dopa tends to underestimate the disease. And
yeah, that's what is said, that DAT transporter imaging is better in the early stages because there is a down regulation of DAT, so you're going to pick up the disease early. And naturally, when you have abnormal dopamine transporter imaging, then you really don't need to go in for F-Dopa imaging. You can, for dopaminergic imaging, you can either choose Trodat and Dopa, and in the Indian context, it depends more on availability.
Like no, my question was, have you ever encountered a case where Trodat was abnormal, but F-Dopa was normal? Have you ever done that? It says in the literature, but have you practically seen it?
Yeah, that is possible. That sometimes when we're not sure.
I had just read it somewhere in literature that in early cases, around 20 to 30% cases, it can be normal.
Yeah,
exactly.
Because in early patients, we would prefer to do dopamine transporter imaging.
Yes.
And if it's available, then definitely DAT imaging is better than going in for Dopa.
Madam, you would agree that F-Dopa has to be superior to Trodat because Trodat uses the gamma camera.
True.
Yeah,
As
so
a imaging modality, PET is superior to
imaging
SPECT.
is going to be far better for F-Dopa than Trodat. I don't do Trodat at all now. Believe me. There's nothing into Trodat.
I totally agree that as an imaging, PET imaging is superior to SPECT imaging. And if you have the availability of F-Dopa, it is something which you would prefer to do because of the convenience also. Like Dr. Ashish said, you just have to wait for 1 hour and you can go ahead 60, 90 minutes, you can image the patient. But the cost issues is something which again has to be taken into consideration, availability and costs.
Yeah, actually what happens in, as you correctly told, in Parkinson's disease, you don't need any imaging, to be very honest. You don't need MR, you don't need 7 Tesla MR, you don't need F-Dopa, you don't need Trodat. When the early part, when the neurologist want to diagnose whether it is essential tremor versus Parkinsonism, that time Trodat is the best agent because there is down regulation in the presynaptic membrane. Whereas why F-Dopa is not good? Because whenever there is a deficiency, you will just like equivalent of iodine. When iodine deficiency gland the goiter, because similarly there is upregulation of the postsynaptic membranes. So because when you use F-Dopa, it tracks from the synapse level to everywhere. So F-Dopa is not good in the early part of the study. That's why Trodat is good. So it is resolution is an issue because PET versus SPECT, but otherwise utility of Trodat in the early part of the PD is much better.
You would agree that it is presynaptic. F-Dopa is presynaptic.
Yeah.
Yes,
That is why. That is what I'm trying to make a point.
Yeah.
Because F-Dopa scan is presynaptic.
No, F-Dopa is always all synaptic. Because F-Dopa goes to the postsynaptic and goes, whereas Trodat is only presynaptic.
Thank you, sir. Now I would like to ask Dr. Sushma, what are your expectations from us, from nuclear medicine and neuroimaging MR? What do you want from us in such a scenario? What do you expect from us?
As Ranjan sir and Dr. Ritu have already deliberated upon when we go for the nuclear medicine and MRI imaging, not in all the patient. When we deal with movement disorders, we typically go symptom-based analysis and phenotype identification. Most of the times we are successful in identifying and diagnosing a patient, but there are times when we have to actually differentiate whether it is an essential tremor or a tremor-predominant Parkinsonism, whether it is a typical Parkinsonism or an atypical Parkinsonism, whether this patient is fit candidate for DBS or whether DBS is not going to help this patient, whether to take that step or not. So, as far as MRI is concerned, whether this is a idiopathic Parkinson or a secondary Parkinson, whether it is secondary to normal pressure hydrocephalus, whether it is a vascular Parkinsonism. So these are the basically things that we are looking for. So accordingly, what we expect, first I'll talk about the radiologist. So accordingly, what we expect from the radiologist, see, we are not looking at radiologists to tell us about, the melanin and other things. Till now, I haven't used that. The things which in our clinical practice we want is that, if there is a normal pressure hydrocephalus, the report should be clear about that. And if you need to do, flow cytometry and more, the radiologist, those things should be available. Availability is a big thing, so those things should be available and we should get report accordingly. Of course, vascular is not a big thing that every radiologist would report. Then from the nuclear medicine specialist, of course, what we want is that if I'm looking at an essential tremor versus idiopathic Parkinson disease, then what is the, whether there is striatal hypo, dopaminergic activity, and if it is there, whether it is symmetric or asymmetric. If it is asymmetric, then whether there is a rostrocaudal, all the things that we know, that we read in text, those things, if they are clearly there in the report, unambiguous way, whether there is a rostrocaudal gradient or not, and overall impression, whether it fits with our clinical impression or not, and if we have access to the nuclear medicine expert, so that not just that the report comes to us, because this thing is not available in all the hospitals. So most of the time, say it is not available in my hospital. So most of the time, I'll be sending this patient to other hospital or other center for the imaging. So we expect that the nuclear medicine expert should be available to talk to us also. If there is any ambiguity, I should be able to pick up my phone and discuss, and we should be able to arrive at a diagnosis which actually helps the patient and not just adds to the literature.
Thank you very much, and this point should be well loud and clear, that we should have an active conversation with our referring physicians so that the patient, basically the patients should benefit. So whenever we have an interaction with the clinician, we know what is the clinical question which is to be answered. Imaging or any investigation can only answer something to the question should be clear, then only the answer can be formed properly. So we should have
I just want to refer that, especially when you're talking of vascular Parkinsonism, the MRI is the one modality which helps. But somehow the MRI is very underreported when it comes to, vascular changes and all. You should be able to tell us that yes, these vascular changes may result in maybe any cause for the symptoms of the patient, which is very important.
So strategically and
all patients have MRI done.
Yeah, and many patients have vascular changes on MRI. So if that's true, but that is, I think that we also have a role to play in that clinically we have to see whether these vascular, or not all patients with vascular changes on MRI will have vascular Parkinsonism. But if that is the answer we are looking for, and if we have strategic infarcts in the basal ganglia and all, of course, if that is reported, that helps us to strengthen our clinical belief. And also to distinguish atypical from typical Parkinsonism, if you are doing a FDG PET, then those specific questions should be answered, whether it is in favor of a CBD, whether it is in favor of a PSP, whether it is correlating to my clinical impression that this could be, either if I'm thinking of a PSP versus typical Parkinsonism. So I should be able to get an answer that this is more likely, those areas.
The stronger the clinical history you provide us, the better we interpret the FDG scan.
The problem is that usually if our clinical impression is strong enough, then we will not even order it. So we'll order it only when we have an ambiguity. And therefore there will be, once we have an ambiguity, that's when we go for this. And these are very good tools, and I think that these are very useful to answer our questions only and only if we and the nuclear medicine and the radiologist work together.
True.
No, so I would
here
like
to support
to just intercede. So typically in vascular Parkinsonism, suppose there is some such case like that, we do mention that there are strategic infarcts. We'll mention, and even like with white matter lesions, we'll be trying to give it a standardized Fazekas classification, so that gives you an idea how bad it is. So of course, that's not every imaging center. We understand that. But coming to the most interesting part, which Dr. Ritu has mentioned, see, when there's a clinical question, even whether it's a clinician, whether it's an orthopedician, whether it's a internal medicine specialist, whether it's a neurologist, a lot of times what happens is that most of the imaging community gets a prescription which is not asking the specific question. Like I'll explain to you. I'll just explain to you. Like for example, suppose the patient does not have a complete triad of NPH. Okay, so he's not, wet, wobbly, and wacky. He's just got one of them, or 2 of them. And you still, like, there are some cases where we find imaging which looks like NPH. And it's known that in some cases of NPH, you might not have the complete clinical triad. It develops over time. So in such cases, we do mention it, and we also say that, look, this looks like it. You'll need to look at it. Please correlate clinically, because you need to check out that.
I never said that you don't mention. I was talking in general.
I think
there are all kinds of reports.
So I would like to ask the neurologist, how confident are you in, saying that these vascular changes could probably result in that Parkinsonism which the patient
Once we
has?
see the patient, and once we are, clinically seeing the patient, and he's not a typical idiopathic Parkinson, and there is a history of strokes, and there are clinical signs which tell us that this is more likely to be a secondary Parkinsonism. And I guess we are, in vascular versus idiopathic, our confidence level is high.
And you would definitely like to do the MR before you go in for the dopaminergic imaging, like in these patients, they would have
MR is more important in such patients.
Definitely.
In such patients, MR would be more
I'd just
important.
like to add one thing. This entity of vascular Parkinsonism is an entity which does not correlate very well to the imaging. Now, it's very difficult that you have a 65, 70-year-old gentleman who's got a hemiparky, who doesn't look like a cardiac, then you're going to find an infarct in the basal ganglia, or you'll find a tragic infarct elsewhere. So I really, as a clinician, the diagnosis of vascular Parkinson's disease, even with any hybrid imaging, I think still happens to be a clinical diagnosis rather than more of a radiological diagnosis. To be very frank with you, I'm sure Sushma and Ritu will agree with me. So we talk so much about vascular Parkinson's disease. I also label them. They're actually not vascular. What they are, I don't know. Whether they're also early degenerative disease of the central nervous system. And they're not vascular. Because again, these vascular guys do not respond again very well to L-DOPA. Ritu, will you agree? Absolutely not. The fact that the patient is not responding effectively to L-DOPA is a point itself against that this is not Parkinson's disease, because the basic criteria for Parkinson's is response to L-DOPA.
Yes, sir. So thank you very much, sir. But this is what we wanted to empathize, that in vascular Parkinsonism, the dopaminergic markers, the imaging markers are normal. So if you have a clinical suspicion of vascular or any other degenerative pathology which is not Parkinson's disease, not striatonigral degeneration, be it a brain iron deposition or Wilson's disease or any other degenerative neurodegeneration which is not striatonigral degeneration, F-DOPA is usually normal. So that may help in making the distinction early. I would like to ask Dr. Neha, what more do you expect or want from our report? If you want any specification or any emphasis on something, can you please tell us if you want something more added to in our reports?
I think most of the important points have already been discussed. Like ma'am have already pointed out, when we're asking for these specific modalities, it's only when, especially, so like we said, when we're sure it's PSP, we've already made the clinical diagnosis. We know that the upgaze is restricted and we know, yes, this is PSP. Or when we know that this is MSAP or MSAC, we know that it is Parkinsonism with predominantly cerebellar signs. So we know in these cases we're not ordering the specific imaging modalities. But it is when there are very subtle signs and it is not classifying particularly into Parkinson's disease per se, that is when we're ordering these tests, and that is when we need the help of these specific nuclear tests when we're ordering them. Or when it is exactly, it's just not tremors, it's more than tremors, when we're sure that it is not essential tremors. We're not getting that history that it's, we don't get that family history, we do not get that benefit from alcohol, there is some kind of a slowness, the rigidity has yet not set in properly, and it's not classifying into Parkinson's disease, and there's an overlap that is coming along with that. It's not, so that is when we're ordering for these DOPA scans, and that is when we need the help of these modalities. And of course, we want the reports clearly telling us, yes, this is falling into the essential tremors or the Parkinson's disease or these specific imaging modalities like we've discussed.
Thank you very much. And with this, we come to our conclusion that F-DOPA with FDG is used for achieving an early and accurate diagnosis with early recognition of Parkinson plus syndromes. However, we still have, we are lacking in the objective patterns or markers to assess disease progression in neurodegeneration. So hopefully we'll have something very soon from AIMS which will help us in monitoring disease progression. So our future, of course, lies with PET MRI. Now, the MRI which is now combined with PET, it's not a good, the machine is low Tesla machine, I think. So in future, when we have a higher Tesla MRI and in combination with PET, I'm sure that will be something which we'll all look forward to, and that will be a true liger, and both two very strong modalities. When we combine them, we'll get something which will be beyond each one's separate scope. Thank you very much, all the panelists. Thank you very much.
Thank you, Dr. Ritu. Thank you, panelists. That was a wonderful discussion, and we are really hopeful that there's a paradigm shift which will put PET and other molecular imaging into the driver's seat for diagnosing neurodegenerative disorders someday. Moving on to our next panel. Personalized medicine is widely discussed but intermittently implemented. Theranostics beyond thyroid cancer treatment has really triggered a dramatic transformation of nuclear medicine. In the last decade, use of Theranostics has seen an unprecedented value of adult cancer treatments. To highlight this more, we move on to our next session. On cancer prostate, molecular theranostics. We'll discuss the investigations and treatment in this panel. To discuss this, I would like to invite the panelists. Dr. Ritesh Monga. He's the Director and Senior Consultant, Urology, Kidney Transplant at Metro Heart Institute, Faridabad. Dr. Manish Kumar Chaudhary. He is the head of the Department, Urology and Kidney Transplant, QRG Hospital, Faridabad. Dr. Shamim, Additional Professor, All India Institute of Medical Sciences, New Delhi. Dr. Madhvi Chawla, she is the Associate Director, Department of Nuclear Medicine, PET-CT, Max Super Speciality Hospital, Saket. Dr. Sagarika Paul, she is Consultant Urology at Sarvodaya Hospital, Faridabad. Dr. Vibhor Sharma, we are still waiting for him. He is the Medical Oncology and Bone Marrow Transplant Unit Head at Yatharth Hospital. Dr. Aftab Hassan, he is Associate Professor, Department of Nuclear Medicine, SGPGI, Lucknow. Dr. Abhishek Raj, he is the Medical Oncologist, Senior Consultant and Unit Head at Sarvodaya Hospital, Faridabad. To moderate the session, I would like to invite Dr. Manoj Gupta, Consultant Nuclear Medicine, Rajiv Gandhi Cancer Institute and Research Center, New Delhi.
Thank you very much. I'd like to thank first Dr. Swagat for inviting me for this wonderful session. I'd like to thank SNMI Northern Chapter for giving this opportunity. I welcome my all panelists. So after the diagnosis, so normally the nuclear medicine is being think of the diagnosing the various diseases, but I think now we are making our impact in the treatment as well. So the role which is assigned to me is the carcinoma prostate, molecular imaging and theranostic, but I will restrict myself to theranostic only. We will see what is the role and place of PSMA directed treatment in the prostate cancer management. I think the PSMA is the prostate-specific membrane antigen, everybody knows here, so I'm not going to detail of it. There's a various way we can utilize the PSMA. There are multiple mechanisms. We can increase the efficacy of PSMA. I'm not going to detail of this. I will start with the case discussion. So I think it's important to know what is the current status of the PSMA-directed treatment. So what is the current guidelines? I'd like to ask Dr. Madhvi if you can tell us what is the current guidelines of PSMA treatment in 2020-22.
As per the current guidelines, lutetium PSMA therapy is a treatment option in patients with metastatic CRPC who have one or more than one PSMA avid lesion and or metastatic disease which is predominantly PSMA positive with no dominant PSMA negative disease, and they have progressed on prior androgen receptor directed therapy and taxane based chemotherapy.
I think absolutely right. I think why I asked the question, because we should know where we place right now. So PSMA therapy is already FDA approved, is approved in 20th March 2022. It is there in the NCCN guidelines now, so it is, as the Dr. Madhvi has said, it is approved in post docetaxel and prior novel androgen therapy status, and it is there in the major European guidelines as well. So these are the revised recommendations. It strongly recommend the use of lutetium PSMA in pre-treated cases. So we'll start with the case. 72 years metastatic prostate cancer, whose patient diagnosed in April 2013. Patient has already received standard line of treatment like androgen deprivation therapy for 5 years, abiraterone for 2 years, enzalutamide for 3 months. And now the patient presented with bone pains and rising PSA. The performance status is 1. So I'd like to ask Dr. Ritesh, what is your take on this patient, how you will proceed?
See, we need to know his, like you have rising PSA, what is the PSA doubling time like, and how is he doing now on enzalutamide? Like he's definitely now a CRPC patient.
Yes, he's a CRPC patient.
Yeah, we need to know the symptomatology, PSA doubling time, and then we have to decide whether to add something to enzalutamide, extra to enzalutamide.
Okay. Even the patient has already failed on abiraterone enzalutamide before. Okay, so the doubling time, the PSA doubling time is less than 6 months. So these are the possible options which I thought. So what are your best option of the first 2 options you would like to see?
See, because patient is a good performance status, so and after having his general liver function, kidney functions, I think chemotherapy would be the first option from my side. And we have to see the bone pains and all along with.
Yes, thank you. Thank you very much, Dr. Ritesh. So I think we have one medical oncologist right now with us. So Dr. Abhishek,
so,
you can tell us.
So at this point, I'd like to do BRCA testing, probably HRR testing more than BRCA. So HRR testing will be there because he's a castrate-resistant cases. Both the docetaxel as well as lutetium PSMA, because there is a widespread PSMA avid disease. But what I have experienced in my clinical practice that if you use lutetium PSMA first, the tolerance to docetaxel in the 4th or 5th line is going to be very bad.
It's otherwise as well.
It's otherwise as well. So he's 72, good performance status. He might not receive the next line of therapy. So probably I'd go for docetaxel. And from the various phase 2 and phase 3 studies, we have seen that lutetium PSMA works even at a very later line of therapy. But probably reserve it after that.
All right, thank you very much, Dr.
And just to interrupt, I would also like to see whether there is any visceral mets or no.
There is no visceral mets, sir. There is a PSMA avid lesions which are mainly in the lymph nodes and the bone. Then the lymph nodes are not big. It's mainly a centimeter size of lymph nodes. Dr. Shamim, what is your take? You like to
see, this patient has already explored the option of conventional therapies. As our medical oncologist colleague has already mentioned, that this patient can be tried with docetaxels or we can see the chemotherapy. But simultaneously, there are many studies, those where the people has compared lutetium response, lutetium PSMA therapy in patient those are having the docetaxel and the patient those are naive to the docetaxels. So both the studies have been, they have compared, and that one study from the Germany, Bad Barkha group, and they have taken 83 patient in pre-treated patient and 84 patient in patient those were taxane naive. So they concluded that progression-free survival was, overall survival was approximately 27 months in case of patient those has taken their PSMA lutetium therapy, as compared to the people or patient those has taken only docetaxel. The overall survival was only 11 months. So there are study. This is very optimistic study, I believe, but there are few study. One of our student who is doing DM in our institute, he was there in the PGI, he did the study, and he compared the patient PSMA plus only PSMA lutetium therapy with only the docetaxel. He included 40 patients, and he concluded that there was not much difference.
Yes.
So
I think I completely agree. The panel is completely saying that docetaxel is the choice here, because we have the phase 3 data for the docetaxel is the TEX327 trial, and for lutetium PSMA we don't have a strong data, probably that may be the reason.
I want to add one thing. Yeah. The patient those are having the bony metastasis, the predominant bony metastatic disease, they will be more, I think, should be considered for the lutetium therapy, I believe.
Okay. I think the radium dichloride is another option we have. Dr. Shimin, do you say anything radium dichloride, radium 223? Is there any role of radium dichloride here?
So you mean to see alpha therapy. So practically and theoretically, yes, alpha therapy is better than the therapy, lutetium therapy, or we can say beta therapy, because of better penetration, because of high LED, linear energy transfer, because of high efficacy, because of less toxicity. So all these points theoretically has the alpha emitter has more advantage over the lutetium therapy. So yes, the patient particularly, what our experience says that the patient those are having the bone metastasis, they should be upfront considered for the actinium therapy.
No, Dr. Samim, I think sir is asking.
Bal sir want to add something into this.
Want to comment anything? Yeah.
Though radium 223 and actinium 225 are both alpha, but they are quite different. Radium you cannot label with any biomolecule, whereas actinium you can label with many of the biomolecules. Like PSMA. PSMA is the vehicle which carrying the actinium, but PSMA cannot be labeled with radium. Radium dichloride is just like calcium, it is analog of calcium. It cannot be labeled with any other biomolecules. So what radium dichloride recommendation was by the FDA was only when you exclude the visceral metastasis. If there is no visceral metastasis and you have got only skeletal disease, say 10 years back, it was only drug available for the treatment of the bone pain palliation, and they never achieved any complete remission. Their survival has improved only few months, 11 months, 5 months to 11 months. So that was the only achievement. But the cost was very enormous, that is very. Whereas PSMA, best whether lutetium or what you are changing is the only you are using the different radionuclide. In PSMA is the carrier. It carries the molecule, binds to the cell membrane, internalize into the cell. So the lutetium, yes, lutetium has got radiation waiting factor 1, actinium has got radiation waiting factor 20, so the effective biological half-life, biological effect is around 7 to 8. So that is 7 to 8 times it will be more effective compared to the lutetium. So, but it is going to treat both visceral as well as skeletal metastasis. That's the advantage.
Absolutely, sir. I think the mechanism of action is different for the radium dichloride and the PSMA-based treatment. But the radium dichloride, if you go with the guidelines, it is a valid option, but may not have a disease control rate. So that is what we want to say.
Valid option when there was nothing.
Yes. Okay,
that was when there was nothing, it was valid option. But when everything is, when there was no CT scan, we used to do X-ray, tomography, this, that. Who is doing tomography in the X-ray tomography now?
Absolutely, sir. So we have a small data, I think from PGI, we have a small randomized study, a non-inferior phase 2 trial of 40 patient lutetium PSMA versus docetaxel. The primary endpoint was the PSA response. 60% versus 40% is the PSA response, and this is their conclusion. The lutetium PSMA was non-inferior to docetaxel. We have a very strong data what the Dr. Bal is saying. For the actinium PSMA, it is coming in a big way. If you see, the PSA response is 91% into these patients, and even the progression-free survival is more than 55 months. But we don't have a phase 3 data to support right now. So I think what the panelists are saying, docetaxel is the choice here. So patient was started with docetaxel. Patient was given 6 cycles of docetaxel, and now again the patient is having a progression. The PSA is doubled in after 6 cycles of chemotherapy. But the disease is still limited to the bones and the lymph node. There is no visceral metastasis. So what are the line of options? Maybe I can ask to Dr. Manish, what is your take on this? What are the line of options you like to take?
So in this scenario, he has already tried taxanes, and still the PSA is rising. So now we can think of giving a trial of lutetium therapy. He is an ideal candidate for the lutetium therapy now. Other option would be to try cabazitaxel as a second line chemotherapy. But considering and looking at the response with the lutetium therapy in the initial trials we have seen, and based on the NCCN guideline also, so he's an ideal candidate who has not responded with chemo and with the ADT. So we can think of giving a lutetium therapy.
Absolutely. Thank you very much, sir. Dr. Sagarika ma'am, what is your take?
Yes, I do agree with Dr. Manish, because since this patient has no response with the primary chemotherapy, either there is one option which is written in the literature, I don't know how much it is feasible, they can go with the challenge docetaxel therapy again, but if not, then it can be followed by the PSMA, I mean radionuclide labeled PSMA therapy. That will be better.
And Dr. Aftab, what is your take?
These patients should be taken for lutetium PSMA therapy.
And which trial you want to quote here is which trial based on lutetium PSMA?
So if you have to choose PSMA versus cabazitaxel, you should refer to a trial, therapy trial. So in the therapy trial, cabazitaxel versus lutetium PSMA, PSMA shown overall PSA response rate better than the cabazitaxel.
Okay, that's true. I think the first trial which established is the Vision trial, which is actually a phase 3 trial. The therapy trial is a phase 2 trial.
Therapy trial is phase 2 trial. And
yes,
they
sir.
have never done a phase 3 trial. For your
this is phase 2 trial, yes, sir.
Yeah, and then they had positive, negative. They use those who are dual literature imaging. They did only those patients who have got PSMA positive, FDG negative only. Whereas in Vision trial is a phase 3 trial, and there was no such selection bias. They avoided and gave everybody, including those patients whether FDG positive or negative, doesn't matter. So
Absolutely.
that's the major difference between Therapy trial from Australia versus the Vision trial, which is a multinational trial.
Absolutely, sir. I think the Vision trial, which is the landmark trial here, which support the lutetium PSMA, but if you see the inclusion criteria, they have not used the FDG PET CT scan. So I should say it's more like a real world, inclusion criteria in the Vision trial. And this is the results of Vision trial, what the Dr. Aftab is quoting here. And there is a better overall survival, better radiological progression-free survival. These were the two alternative primary, outcomes. The PSA response is 46%, and the primary, symptomatic skeletal event, wonderful, 50% less chance of symptomatic skeletal event. And even the toxicity data shows that not much grade 3, grade 4 toxicity. Major toxicity was the bone marrow suppression. Major was the anemia, which is 12.9%. There was not major interruptions during the trial, not major, discontinuation from the lutetium arm. And another thing we need to know that these patients in the Vision trial, all patients were post-docetaxel, and the 40% of the patient was even post-cabazitaxel. So these patients were heavily pretreated patients, even though we are able to get the overall survival benefit. So I'd like to ask our medical oncologists, why not cabazitaxel?
So first of all, we've seen that patient is a primary progressor on docetaxel. So cabazitaxel is a congener. First of all, the toxicity is pretty bad. The tolerance to the initial trial of cabazitaxel used 25 mg per meter square. I don't think anybody is using that. We're using 20 mg per meter square, and even to that, we have a trial of therapy trial now available in which patient has progressed on the newer hormonal agents. And in this also, if the FDG avidity is high, plus if you see the 2002 ASCO presentation, 2022 ASCO presentation of the update of this trial, so they've seen that if the PSMA avidity is very high, the response rates, the chances of 50% response is as high as 91%. And with cabazitaxel, it is just 40%. And even in patients who are having low FDG avidity among the included patients, there also the response to lutetium is higher than cabazitaxel. So if the response is there, good quality of life, that is what we are trying to achieve in a patient who is heavily pretreated.
Thank you, Dr. Vishek. I think it's good to see the medical oncologists now supporting the lutetium PSMA. So we have already the stand
the
of
problem
lutetium
is the
PSMA.
sequencing, where you want to come to a picture. It is a self-referral bias. A medical oncologist, unless they thak jata, wo nahi bhejega tumhare paas. It's only the question of sequencing.
So that is why I want to know, what is the sequence, what is the best drug to use?
Sequencing is after the androgen deprivation therapy, when the patient is progressing, whether you will go to the chemotherapy or go to radionuclide therapy. Radionuclide therapies are always safer, and that little bit of 10 or 12% of anemia may be due to the extensive skeletal mets. That also contribute to the anemia. It's not that because of the therapy it is anemia. Otherwise, radionuclide therapies are very, very safe.
Dr. Madhvi, lutetium PSMA or cabazitaxel, what is your take? Suppose the patient is agree for both. How do you convince your patient, lutetium PSMA or cabazitaxel?
Well, based on the therapy trial, which showed good PSA response rates, good progression-free survival, less grade 3-4 toxicities, I think it is lutetium PSMA would be a better option. I mean, if the PSA response were like 29-30% overall better in lutetium, and then even the progression-free survival was better, 20% versus 3%.
Absolutely.
Toxicities, yeah, grade 3-4 toxicities were also much lesser, I think about 35 versus 50%. So yeah, on the whole, I think lutetium PSMA should be a better option.
But do we have any survival data for this from therapy trial?
Yeah. When they assessed the survival data, the overall survival at the end of 3 years, both the studies showed similar overall survivals. And besides that, in fact, even in the patients they excluded from the trial, when they studied them later, they had seen that they had lower median survivals as compared to the patients who were taken in for the trial.
Absolutely, ma'am. I think you are absolutely correct.
And I think at this point, sir, when the patients have already been heavily pretreated, a difference in survival is probably going to be very difficult, because most of the patients, they end up achieving the second line. If you are receiving lutetium PSMA, he'll go on to receive your cabazitaxel when they progress. Same for the otherwise. So that is why I think achieving a survival difference at this point is going to be difficult for any trial if it is there. So I think that is why OS becomes a moot point at this point.
Most of the trial is actually mixed with, that is called lag time advantage. So you are going to give docetaxel, you will get for 10 cycle before you send to us. So that time is gone. Suppose I treated, say, point A, either this patient goes to cabazitaxel, and then from the cabazitaxel it comes back to me, and the person who is getting upfront lutetium therapy, he has got advantage of that time. Even if you don't treat, some patients are not going to die in 10 days or 20 days or 30 days. There is natural, it is always a Gaussian, there is a skewed curve. Some of the even GBM patients, they survive 5 years.
Absolutely,
so that you take that advantage, time lag advantage in oncology, and none of the trial can actually, as you correctly told, none of the trial can actually calculate, if I would not have treated this patient, how long it would have done. Then you have to do a natural study, which is not medically or ethically acceptable.
So this is what happened with the Mosno trial. There is a crossover. So what is happening in the therapy trial after the end of the trial? If you see the lutetium arm, 32% of the patient receive cabazitaxel. And in the cabazitaxel arm, 20% of the patient lutetium PSMA. So what is happening here? The patient has received lutetium PSMA followed by cabazitaxel, or cabazitaxel followed by lutetium PSMA. So this is what happened with the therapy trial, and that's why probably we don't have the survival benefit. But if you see the primary endpoint of this trial was the PSA response. This trial was not made to look for the overall survival because it was not that strong enough. So the trial was able to achieve its primary endpoint, but not able to achieve secondary endpoint, maybe because of the number of patients were less, and maybe we have a bigger phase 3 trial, maybe we are able to achieve something. And what the Dr. Madhvi was saying is absolutely right. OS benefit is not there, but there is definitely a benefit of the radiological progression-free survival. So this patient suppose come to, Dr. Shamim, to you. Now, what is the role of FDG PET-CT scan? Do you do FDG PET-CT scan in all patients before planning a lutetium PSMA, or you just, based on your PSMA scan, you plan for these patients?
when we are planning for the therapy, I think FDG PET-CT has no role. So in these cases, we actually, if we are planning to give the therapy to this particular set of the patients, so gallium PSMA is mandatory, because that is going to guide us that this patient, all the lesions are picking up the uptake or not. So if there are some criteria fixed for that. So FDG in PSMA, in prostate cancer has not much role, particularly when we are planning the therapy.
Any cutoff you take in your practice for lutetium PSMA, like more than 10, more than 5, or more than 20? Because if you see the therapy trial, they have used more than 20 in at least in one lesion, more than 10 in all lesions. If you see the vision trial, they have used just as a lever as a background, should be more.
So we also take lever only. We don't take the number or SUV values. We take if the patient SUV max is more than lever or equal to the lever, then that it may be the right candidate for the therapy purpose.
I think absolutely. I think what is there in the real world situation, what you are saying, Dr. Shamim, is absolutely right. So if we take the FDG PET-CT scan in scenario, like which is happening in therapy trial, the dropout, or you can say the failed patients who are not, screen failed patient is almost 28%. And in the vision trial, the screen failed patient is only 13%. So that is why probably you will use the best patients in your scenario. So just like to say just what the Dr. Abhishek has said.
Another point I wanted to make was, if my PSA is not very high, but on the CT scan I see that there is a very large disease burden, I would suspect something like a small cell transformation. So this is what I have learned from sir and sir, that there what we need to do your FDG PET, and probably repeat a biopsy at that point.
So probably this is the, if you see the inclusion criteria in therapy trial, they've said the PSMA plus positive and FDG negative are the best patient to be treated, and PSMA positive and FDG positive are the second best patients. And if you have a PSMA positive and FDG positive but discordant lesion, or PSMA negative and FDG probably not will going to response to lutetium PSMA treatment. So maybe the prognostication with the lutetium PSMA treatment, the FDG PET-CT has a role. And if you see the therapy trial, the results, the patients who were screen failed, they have performed very bad, even though patient has received cabazitaxel, and if you see the curve is even lower than the cabazitaxel. So even for the cabazitaxel patients, those who were screened, failed, they have performed bad as compared to cabazitaxel. So maybe for the cabazitaxel also the FDG PET-CT has a prognostic role.
That's because they have a very difficult disease biology.
Yes, thank you very much. Yeah. And another thing which I want to make a highlight here, the lutetium PSMA, if you have SU mean more than 10, the therapy trial has said the odds ratio, the strength of association is almost 12.2, so probably the SUV mean more than 10 is a cutoff. The similar data has come from the vision sub-study, SUV mean more than 9.9, you have a best overall survival. So probably the prognostication of the patient is become better by using the FDG PET-CT scan. So lutetium PSMA or olaparib. Dr. Ritesh, what is your take? So you like to go for olaparib or lutetium PSMA? Suppose the patient is positive for HRR mutation, cohort A mutations or cohort B mutation. Does it make any difference for you?
I don't think I have any experience with olaparib and all, so I'm not the right person. Some other
Okay, maybe Dr. Yeah,
sir, so around 30% of the patients are positive for HRR mutation, and out of these, cohort A are the ones which do respond, which is, and among them also it is the BRCA2 and ATM, which is, and CHEK2, which are the most predominant mutation which end up responding. There was a big problem in the PROFOUND trial that the comparator arm, I think it was not good. There they have used newer hormonal agents as so if the patient has been started on abiraterone, there is a chance that he might respond to enzalutamide in the second line. But if the patient has been given enzalutamide first, then the response to abiraterone is virtually 0%. And there were 30% of the patients who had received prior enzalutamide. So I'm not too convinced with olaparib data, even in cohort A. But yes, if the patient has exhausted all the therapy options, he is HRR positive, I'll probably go for olaparib then only.
Okay, so patient with HRR cohort A mutation versus lutetium PSMA, what is your take?
I think since it's a, what do you call it, now that we have even rucaparib available, olaparib is slightly difficult to afford, and I think in prostate cancer their support program is also not there. So cost of therapy also becomes important there. So I'll probably go for lutetium and then maybe try olaparib.
Okay. Dr. Aftab, lutetium PSMA or olaparib?
So anytime lutetium PSMA is better, because this olaparib that works only 30% of patient who has mutation in DDR gene. And second thing, if you look on the PROFOUND trial, So, and look at the control population. So this control population overall survival was 15 months. And you compare with the vision trial. Vision trial, control population has a survival of 11 months. So this profound trial already has an advantage of 4 months when you compare with the overall survival. So yes, you should go for the lutetium PSMA therapy.
Thank you very much. I think in the post...
Plus olaparib, see, cross-trial comparison is slightly difficult. I'm not a big fan of cross-trial comparison. But if you look at the data for olaparib, they were not as heavily pretreated as in the vision trial. So that's probably my take. So I'd still be very skeptical. AstraZeneca people, they always like promote olaparib like anything. But even in cohort A, I'm not a big fan. I'm yet to see a response.
So olaparib, 2/3 of the patient were previous taxanes, and the 1/3 of the patient was, the pre-taxanes. Yes, absolutely. So even though, I feel the toxicity point of view, the PSA response point of view, the lutetium PSMAs appears to be better in this particular scenario. So this patient was planned for lutetium PSMA. Patient was given 2 cycles of lutetium PSMA. The PSA down from 94.6 to 20.9 after 2 cycles, and the patient was planned for another 2 cycles, and the patient has further response. Both the radiological response and the PSA response was there. So just a real world scenario, because see, if you see all this investigational trial, what we see the performance status 0 to 2, but what we see in our clinical practice, the performance status 3 or sometimes 3.5 or even 4. So what is your take, Dr. Madhavi? So does the performance status make any difference into the patient response?
I think it would make a difference in the patient response. I mean, patients with lesser amount of disease would respond better. So yeah, the disease is lesser, maybe the staging is better. So
I think absolutely true. I think the performance status is a key factor in the patient response. We have a small data which we have presented for the patient with low performance status. The PSA response is only 31.2%. Even the patient with visceral metastasis, the responses were less. So we need to be, when we are counseling the patient, the counseling has to be in that way that the patient may not respond. And Dr. Sagarika, what is your take? Even in the chemotherapy, do you think the the performance status of the patient makes a difference?
Yes.
Okay, just a last case, maybe the 3 slides. So this patient, 70 years, MCRPC, multiple lines of treatment, received all the lines of treatment. So he has, consumed ADT, denosumab, docetaxel, cabazitaxel, abiraterone. MMR is proficient here, and BRCA1, BRCA2 mutation is negative. So Dr. Abhishek, do you have any option for this patient?
Options at this point are probably going to be experimental. We had a very interesting data for bipolar ADT. So bipolar ADT is using a supra-threshold dose of testosterone. So just like your GnRH analog, that is how it works, that if you give a very high dose of testosterone, it actually paradoxically suppresses. So even in a heavily pretreated patients, in some of patients it has worked. Of course, we need to be very sure that patient is not into any impending spinal cord obstruction or any impending urinary obstruction. So in such patients you can use, or maybe another thing is we often re-expose the patient to the therapy which he has worked the longest. So probably abiraterone, he has, I think, responded to the longest duration of therapy, so maybe reintroduced abiraterone or something like that.
Okay, so lutetium PSMA, it's not been tried yet.
Oh, it's not been tried. that is always an option, yes, sorry. I thought he has already received.
Okay, so this is a different case. The patient has a diffuse metastasis. If you can see, all strongly PSMA with liver metastasis. Penile was diffusely infiltrated, multiple, the lung nodules, the multiple bone lesions. So what is your take, Dr. Shamim, actinium PSMA or lutetium PSMA?
Considering the fact this patient has been explored many therapies, still I will go for the lutetium PSMA therapy. As per the literature and as per the convenience, as per the cost is concerned, I think we should reserve actinium PSMA therapy, and we should try lutetium PSMA therapy. Particularly in this case, the disease is not so much of skeleton oriented. So in this case, I think trying lutetium will be more appropriate as compared to the actinium. And actinium, we can keep it in reserve, and we can treat this patient later on if it shows progression on the lutetium PSMA therapy.
Absolutely true. Dr. Aftab, what is your take, actinium or lutetium?
Lutetium PSMA, and actinium should be reserved if it is not responding to lutetium PSMA.
Okay, I think there is a small amount of data which has come from All India Institute of Medical Sciences. It's a prospective trial which has been presented on actinium PSMA. The PSA responses is 39%, urostomia is 29%. There are certain retrospective studies are also available. The maximum, the series is from Mike Sathige, 73 patients. 70% is the PSA response rate, urostomia is 85%. But this patient, want to have a best response rate. The affordability was not an issue. The patient was counseled for both. Patient opted the actinium PSMA as an option. Patient was given 2 cycles of chemotherapy. You see the amount of response the patient has. All the lesions just melted away, the penile lesion, the liver lesion, the lung nodules, everything just melted away. The second scan is almost looking like a normal PSMA scan. Another 4 cycles were given. The patient again has a stable disease. Then again 2 cycles were given. The patient, you can see the lung nodules. In fact, the bone lesions started coming, and the PSA started rising. Patient was having a recurrent UTI, and so we are able to give this patient, after ending all the line of standard treatment, the PFS of 14 months and overall survival of 19 months. So this kind of response we have from actinium PSMA, but again we don't have a phase 3 data. So what I can conclude, maybe Dr. Ritesh, if you want to make any comment on this.
It's a very, very good response. We don't have, I think, most of the places doing this. So we have not seen patients, rather I'm having a look at the first patient who has undergone actinium scan, actinium targeted therapy. So it's a very good response in this end-stage CRPC, which has been exposed to chemotherapy and everything.
All right, thank you. So what is the conclusion from the panel? I think pre-docetaxel.
I want to add one thing in this patient. Here. So this progressive kind of patient, whatever therapy you are going to give, ultimately patient is going to be resistant to that therapy. So don't jump the queue. Just go with the protocol, ADT, then chemotherapy, lutetium therapy, and that is then actinium therapy. Don't jump the queue.
Yeah, absolutely, doctor. I think.
Okay. ADT, yeah.
Okay. So what is the conclusion, I think, from the panelists, all the panelists, that the pre-docetaxel, probably the lutetium PSMA may not have that much of role. We don't have a strong data. So followed by 2 anti-hormone treatments, we have to go for docetaxel chemotherapy, and post-docetaxel we have a strong data of lutetium PSMA, so we should use lutetium PSMA, and the actinium PSMA we can reserve after the lutetium treatment, or maybe in the clinical trials we can include the patient for actinium before the lutetium. So I think this is what is the take from the panel. Thank you very much.
I just wanted to put one word. This anti-androgen therapy or androgen deprivation therapy both actually helps the overexpression of PSMA receptors. So what Dr. Satke's paper was initially showing, that was when they give the anti-androgen therapy for 6 to 8 weeks and then give PSMA, they did better than those who are upfront given PSMA therapy. So it is better to start with the uro-oncologist and then talk to the medical oncologist. Either you can take the patient or I can treat the patient. That's the way. It is a better cooperation. And you have option for later, as Aftab told, all of them therapy will fail at the end. Only you are prolonging the life. You can get 14 months, 18 months, 26 months, 30 months. That's that.
Thank you very much. I think Dr. Bal has concluded the session. So thank you very much, sir. I'd like to thank all my panelists for the wonderful discussion. Thank you very much. Yeah.
Thank you, Dr. Manoj. That was beautifully summarized, and it's really heartening to see our oncologists, our medical oncologists, our urologists believing in the radionuclide therapies. It won't be much of an effort when we have to convince them for actinium therapies in future. Moving on to the next session. So the next panel discussion is on neuroendocrine tumors, the same as molecular theranostics, investigations and treatment. For the panel, I would like to invite Dr. Praveen Bansal. He is the Director, Medical Oncology at Asian Institute of Medical Sciences, Faridabad. Dr. Amish Chaudhary, Director Surgical Oncology, Sarvodaya Hospital, Faridabad. Dr. Nolin Sinha, Senior Consultant, Chief Nuclear Medicine Services at Artemis Hospitals, Gurgaon. Dr. Vinay Samuel Gaikwad. He is the Director, Surgical Oncology, C.K. Birla Hospital, Gurugram. Dr. Sugandha Dureja. She is Consultant, Nuclear Medicine, Theranostics at Action Cancer Hospital, New Delhi. Dr. Dharmendra Malik, Consultant, Nuclear Medicine, Fortis Memorial Research Institutes, Gurugram. Dr. Mukesh Patekar. Dr. Mukesh is here. Dr. Tarun Jain, Assistant Professor in Department of Nuclear Medicine, PET-CT, Mahatma Gandhi Medical College, Jaipur. And to moderate this session, I would like to invite Dr. Nishikant Damle, Additional Professor, Department of Nuclear Medicine, All India Institute, New Delhi.
So, good evening, colleagues. Thank you, Dr. Swagat and Sarvodaya Healthcare for organizing this wonderful event. Thanks to the SNMI Northern Chapter also. So, today our panel discussion, the last in the series of the 3 discussions, is on PRRT for neuroendocrine tumors. And we have a panel of esteemed physicians amongst us. So, I'll start off by putting forward a case, and we'll take the discussion forward from there. Right. So we start off with the case. So there is a 33-year-old male patient, a resident of Ghaziabad. He is a salaried professional by occupation, married, doesn't have kids yet. He presented with chief complaints of abdominal pain on and off since 1 year and weight loss since 1 year. He was apparently normal. Now this happened in March 2016. He was apparently normal before that. And then he started developing abdominal pain, which was off and on in the right hypochondrium, insidious in onset, a dull aching kind of pain with mild increase over a period of 1 year. There are no associated symptoms of vomiting or diarrhea, no aggravating or relieving factors associated. The patient gave history of weight loss of around 6 to 7 kgs in 1 year. Simultaneously, this guy was getting evaluated for hair transplantation also. Now, there was no history of fever, loss of appetite, jaundice, abdominal distension, hematemesis, melena, no urinary symptoms, no history of trauma, no breathing difficulty, no chest symptoms. He informed that he was HbA1c positive but could not provide supporting evidence. No similar illness in the past, no comorbidities, no history of malignancy either in him or in his family. He consumes a mixed diet, his sleep and appetite are normal, bowel bladder habits are normal, he is not an alcoholic or a smoker and has no other addictions. So on general examination, he was conscious, oriented, cooperative, well-built, well-nourished, had no significant signs. His vitals were okay, as you can see. Systemic examination also did not reveal any abnormality. You know, the upper abdominal examination was normal, CNS, RS, CVS was also normal. However, somebody advised him an ultrasound abdomen as part of workup before going for a hair transplantation in another hospital, and they reported that he has multiple liver SOLs. That is how he was referred to our institute. So here he was evaluated with a CBC, RFT, LFT which were normal. A repeat ultrasound abdomen done in-house confirmed the findings reported outside. An ultrasound guided liver SOL FNAC revealed metastasis from a neuroendocrine tumor. and a biopsy showed a grade 1 NET with a Ki67 of less than 2%. He underwent a gallium dotanol PET CT, which showed multiple SOLs in the liver, which are strongly positive for SSTR expression, with retroperitoneal and mesenteric lymph nodes, and a serum chromogranin A was 5600. The image here is in front of all the panelists and the audience members. It's a self-explanatory image. I need not elaborate the details. You can see there is a lot of disease in the liver. Now, my first question is to Dr. Praveen Bansal, sir. What are the different types of NETs and how do they present usually?
Basically, the spectrum of neuroendocrine tumor is very vast.
Yes.
It may be very aggressive, it may be very indolent. Like in this case, patient is having history of pain in abdomen and weight loss. Except that, and pain was not so severe. That's why he was having this problem for 1 year. So it depends upon the spectrum of the disease, whether Ki67 is very high or very low. So this patient is having basically indolent type of disease. That's why having a lot of meds and still he is having not so much problem.
So my next question is to Dr. Amish. Sir, what investigations help us to reach a diagnosis of neuroendocrine tumors?
So essentially, as for all other tumors, one is histology, the other is stage, and the other is supportive biochemical evidences. So in this case also similarly, if there is an imageable lesion found, most neuroendocrine tumors will be incidentally picked up, or rarely if the patient is having a secreting neuroendocrine tumor, only then the symptoms are there. So generally, once it's imageable lesion is there, we have to get a histology either by FNAC or by TrueCut, or if it's a GI primary, then endoscopic ultrasound guided FNA is the foremost thing that we have to do. And the other thing is DOTA-PET is now well established to be a diagnostic modality of choice. So, and it is now widely available, at least in Delhi NCR it is widely available. Most centers are doing it. So DOTA-PET is the first choice for staging.
So now in this patient there were some questions. Surgery or no surgery? Now in this patient, the primary was unknown. Hepatectomy was not feasible because both lobes of liver were involved with mesenteric and retroperitoneal lymphadenopathies. This brings us to an interesting point. In neuroendocrine tumors, which can have a varied presentation, they may just be localized or be extensively metastatic, sometimes resectable, sometimes not resectable. My question is to Dr. Gaikwad. What are the surgical options in the treatment of NETs, sir?
So basically, there are three main indications for surgery. It's on the board here. One is with limited disease, in which the surgeon usually plays the maximum role, is when we aim for the cure and do a curative resection like any other malignancy or tumor. The other one is cytoreduction, at least with removal of at least 90% of the tumor bulk, and palliation like in any other malignancy. So basically the point that I'm trying to emphasize is there's a wide spectrum of surgical radicality. I don't know if I can speak more. So we've done there's an old paper, we published more than 100 cases when I was in Tata, and about 20% were functional. I'm talking about JEPNETs, gastroenteropancreatic neuroendocrines, and since it's a referral center, most of us were high-end, duodenal-pancreatic, usually for high-end people with extended lymphadenectomies and so on. But yeah, a lot of organ preservation, enucleations for insulinomas. So when we're talking about a tertiary center, we get less, simple cases like enucleations and more radical cases with and the only statistically significant factor we found in prognostication was the presence of metastatic disease at presentation, unlike other trials that were done abroad. We have done a few centers. I mean, Dr. Nolin, as Dr. Ishita, so on. We have done some very interesting cases in which we have used lutetium therapy initially, especially when there's limited liver metastasis, controlled the liver disease, then done local.
So you used it in a neoadjuvant setting.
Yeah, like a neoadjuvant, although there was not very high evidence. I'm talking about like 8-9 years back. And then we went in for the primary with maybe liver-directed therapies for the liver lesions if they could be localized on ultrasound.
Right.
And so on. So yeah, so these are some of the pictures. I thought I'd show some for the colleagues here. And intra-PET, yeah, SPECT, after we remove the tumor, to confirm that we've seen some primary lymph nodal. You don't have a primary on your case, right? I think your primary tumor is not identified on your.
Not identified
so there are some cases we've reported on primary lymph nodal neuroendocrine tumors as well in the abdominal region.
Okay, so these are some slides that Dr. Gaikwad has shared with us, showing the different kinds of surgeries that he has performed. Next question to you, sir, is in the case of pancreatic neuroendocrine tumors, when would you prefer to do an enucleation?
The only time I would consider it would be a low-grade tumor like an insulinoma, in which the pancreatic duct is not impinged upon or involved by the tumor. Anything more than that, I would probably go for. If it's in the neck, maybe a central pancreatectomy. We've done some central pancreatectomies for insulinomas, but I don't think the enucleation could be anything more than that as an indication.
So this particular patient actually underwent 4 cycles of lutetium-based PRRT with the dose being 150 millicuries per cycle, along with capecitabine. A repeat PET-CT done in follow-up showed stable disease, and the serum chromogranin A actually reduced from 5,600 to 2,900, which further reduced to 2,200. So my next question is to Dr. Noaleen. Ma'am, what is the role of lutetium-based or beta particle-based PRRT in neuroendocrine tumors? When would you give it? How much would you give it? And what would you do for nephroprotection?
Okay, so in this patient, I see you've gone upfront, you've given PRRT.
Yeah.
So, if you go by the typical guidelines, one goes for cold octreotide. Upfront is also has a role now, though it has not come into the guidelines, but there are a lot of studies that show an advantage of upfront PRRT. This is normally given, 4 cycles of PRRT is given, around 200 millicuries per cycle at intervals of 8 to 12 weeks.
Yeah.
So, of course, there are certain parameters we have to be sure about the blood counts, the liver function, the kidney function. We have to make sure they're okay within prescribed limits.
So can you tell us a bit about the Krenning score that is used?
Krenning score is based on the Dopaminergic uptake on the scan, and we have a score of 0 to 4. So 0, there is mild uptake. 0, there is hardly any uptake, faint uptake. 1 is mild uptake. Krenning 2 is less than the liver, 3 is more than the liver, and 4 is more than the spleen. So normally 3 and 4 are good candidates for us.
Right. So you have mentioned some off-label indications also for lutetium PRRT here. So moving ahead, you see PRRT with beta-based emitters is done using yttrium-90 as well as lutetium-177. So can you just compare it for us? What are the advantages and the disadvantages of both?
Yeah, so as the table shows you, yttrium-90 is a high energy emitter with energy of 2.2 MeV, while lutetium is a medium energy beta emitter with an energy of 498 keV. It also emits some gamma radiation, which helps us in imaging, gamma rays of around 208 keV and 113. Now, the penetration of yttrium-90 is more than lutetium. It's between 3 to 11 mm, the yttrium-90, while lutetium is around 2 mm or so. So where you have larger tumors, you can think in terms of yttrium-90. Smaller tumors, lutetium. The issue is availability of yttrium-90. Commercially, it is not available to us, though I think BRIT has supplied to RMC, because I've seen some papers where they've talked about treatment with tritium-90 PRRT, but to the rest of us, it is not available.
Right. So my next question is to Dr. Sugandha. Can you just let us know what are the protocols used for nephroprotection during PRRT?
Right.
And is there any difference in the nephrotoxicity for alpha-based PRRT and beta-based PRRT?
Right. So basically, the idea, the whole premise of nephroprotection is because the peptide goes towards the proximal tubules where it can stick and cause radiotoxicity and damage. So what we do to protect the kidneys is use arginine and lysine. These are the main two amino acids that are nephroprotective. So we use amino acid infusions to basically protect the tubules from, and they go and stick to the tubules, and they prevent the absorption of the peptide. So we use amino acid infusion for nephroprotection, which is fairly protective. Both for lutetium and actinium, amino acid infusion is definitely needed and helpful.
So, Dr. Noaleen, any comments about the NETTER trial?
So basically this NETTER 1 trial was done under Dr. Strasberg from Florida. And it involved 229 patients over 40 centers in 8 countries.
Yeah.
So they took up well-differentiated grade 1 and 2 neuroendocrine tumors, which were locally advanced or metastatic. And they used this trial, they compared lutetium dotatate PRRT along with cold somatostatin, octreotide LAR at 30 milligrams IM once a month. That was compared with a high dose, 60 milligram of octreotide LAR. And basically the primary endpoint was the progression-free survival in this. Yeah. So they found a difference in the progression-free survival of, it was around 40% versus around 18% or so. The objective response rate in the lutetium arm was around 18% versus 3% in the control arm. Overall, not much clinical significance in the overall survival. It was 40% versus around 35% or so. Sorry, 46 versus around 34%.
All right. Dr. Sugandha, would you like to say a bit about the toxicity associated with PRRT? Right. Is it significant enough, or is it a very safe therapy? What would you like to share with the audience?
So most of the trials show that the hematotoxicity is transient and limiting.
Yeah.
It usually happens by the first or the second week of post-PRRT administration, and recovery is spontaneous, usually not requiring any supportive care or transfusions, and it is self-limiting.
True. So this patient actually received a total of 9 cycles of actinium dotatate PRRT also, starting from 20th of August 19 to as late as 2021. And you can see that the chromogranin value has reduced almost to 300. Serial PET scans have shown remarkable response. You can see in image number 1, 2, 3 and 4. The 4th image, the disease is hardly evident. So this is after treating with beta-based PRRT followed by actinium-based PRRT. So my question to Dr. Dharmender, when would you think of alpha-based PRRT? How much would you give? And any special comments different from beta-based PRRT?
Yeah, specifically the principle with alpha PRRT remains the same as that of beta PRRT. The only thing we are replacing the radionuclide that is able to deal high energy that cause more double standard DNA breakage that are quite difficult to repair, and that will lead to the death of the cancer cell. So we are getting a far better response as compared to the beta particles. So these are the certain studies. We are able to find 5-6 studies that show the alpha particle PRRT response even the patient pre-treated with the beta PRRT. Most of these studies say we are able to get response in 50 to 70% of patients. But we have still a nascent data about the phase 3 trial. Most of these studies are limited with 10 to 20 or maximum of 30 number of patients.
So you have shared some images with us.
Yeah, these are the image that show starting with first image. These are the widely spread metastatic disease of patient who was initially treated with the beta PRRT and then followed by the alpha PRRT. If we go by the second image, there the liver metastatic along with primary, the alpha therapy leads to the near complete resolution of the liver as well, the primary metastatic disease. So I think alpha particle able to perform quite good and they provide better response as compared to beta, but we don't have right now any direct head-to-head comparison as compared to beta versus alpha, and most of the patients are treated with prior with the beta, and if they progress further on the beta therapy, we can go forward with the alpha PRRT.
My next question is to Dr. Tarun. Tarun, can you please tell us how would you assess response in neuroendocrine tumors? What criteria would you use?
Sir, as like other diseases in the response assessment, we are using the all three parameters. As like other diseases, we are using all three parameters: clinical parameters, biochemical parameters, and imaging parameters. In the biochemical parameters, we are commonly using the serum chromogranin A in the neuroendocrine tumors. We are serially evaluating after the giving the treatment. And generally, during the assessment of the serum chromogranin, you have to be aware patients should not be on proton pump inhibitor. It causes the falsely elevated the serum chromogranin levels. And in the clinical parameters, generally we are assessing the clinical signs symptoms at the baseline, and we are assessing even after the giving the treatment. If patient is clinically better, then we are giving the responding to a treatment. In the imaging parameters, generally we are using the RECIST criteria 1.1. Actually, PERSIST criteria is not helpful in the for the neuroendocrine tumor response assessment. Generally, we are using the RECIST criteria 1.1 for the assessment of the neuroendocrine tumor for imaging wise.
My next question is to Dr. Mukesh. Mukesh, welcome to the CME. Could you tell us about the WHO classification of neuroendocrine tumors and the prognosis that differs according to the different grades?
Basically, the neuroendocrine tumors have been, there are neuroendocrine tumor and there are poorly differentiated neuroendocrine carcinomas. In NET, we have grade 1, grade 2 and grade 3 neuroendocrine tumor based on the Ki67 and mitosis. So if the grade 1, they are well differentiated on morphology, and the Ki67 is generally less than 3%, and if they are 3 to 20, then they are grade 2, and more than 20 is grade 3. So depending upon the Ki67 and this mitosis, it's classified. And if these both two things are used, like mitosis and Ki67, sometimes we get discrepancy between Ki67 is less and mitosis is high. That time, whichever is the highest, then it is graded as per that grade. And secondly, there are certain poorly differentiated, or they behave like a neuroendocrine carcinoma or some large cell carcinoma. They are a bit aggressive and they require cytotoxic therapy. So prognosis of the grade 1 is grade 1 and grade 2 is better than the grade 3, and if you compare carcinoma, they do invariably very bad.
Is there any role for immunotherapy or TKIs in the treatment of neuroendocrine tumors?
Yes, definitely they have, but they are in maybe after third and fourth line. Basically, in neuroendocrine tumor, we have somatostatin analog like octreotide, lanreotide. Then we have this NETR trial, which has established the role of PRRT therapy. Apart from that, when the patient progresses, there are various options. Either we can double the dose of somatostatin analog, or we can change to the everolimus based therapy, which is quite often effective in most of the patients, and that will give PFS around 5 to 6 in that particular cases. Similarly, we have a TKIs like we have data for pazopanib, we have data for sunitinib, sorafenib. They have shown to have better tumor control because it has been seen that these neuroendocrine tumors are relatively vascular, and they do have this receptor, and getting this TKI might be helpful in those cases. Similarly, there are some phase 1, phase 2 studies which have shown that addition of capecitabine and along with the bevacizumab, they do give good disease control over the period of time. And definitely the data for immunotherapy is evolving. I have personally not used any immunotherapy in the well-differentiated NATs, still we have scientific data that it can be an option. So we have a lot of options in neuroendocrine tumor, and definitely the role of chemotherapy is also important. If the Ki67 is high, grade 2 and grade 3, definitely in grade 3 we generally treat with the patient with etoposide and carboplatinum based therapy. So in grade 2 there is a gray area which one to use. If the Ki67 varies from, if they are around more than 50%, then giving cytotoxic therapy like capecitabine, temozolomide, they can be effective than giving only sandostatin or PRRT therapy. So depending upon the Ki67 level, we can plan our therapy. So we have multiple options in NAT, and definitely low grades are going to do very well as compared to advanced.
Prognosis remains very poor for the neuroendocrine carcinomas and the grade 3.
Yes, grade 3.
So which brings me to my next question, Dr. Sugandha. Could you please explain us what is this net PET system of classification of neuroendocrine tumors? How would you decide whether a patient is amenable for therapy using lutetium or actinium PRRT based on the positivity on somatostatin receptor scans and FDG?
Right. So NetPET is a scoring system we are using to guide patient selection for PRRT and also for prognostication.
True.
So in patients where we see tumor heterogeneity and the gallium uptake is low, an FDG PET is also done. So we grade these scores from P0 to P5, P0 being somatostatin receptor negative and FDG negative tumors. Then P1 being tumors which are somatostatin receptor positive but FDG negative. P3 coming to the midline where there's some part of the tumor that's positive on FDG as well as on somatostatin receptor. And to the other extreme, P5 where it is only a FDG positive tumor, somatostatin receptor negative. These patients are the ones who are probably the not at all good candidates for PRRT.
Right. So anything that you would like to add about treatment sequencing and any special mention of any guideline from NCCN or ENETs that you would like to quote?
So we have, definitely we have PRRT is established part of the NCCN and the ENETs guidelines now. We have very elaborate guidelines as per ENETs for management of neuroendocrine tumors, which also includes PRRT. Usually, the NCCN guidelines are mentioning PRRT as a second-line treatment after somatostatin analogs. Once there's locally advanced metastatic unoperable disease, we go on after somatostatin analog failure to PRRT. The other options especially for your neuroendocrine tumors of the pancreatic neuroendocrine tumors, you have multiple chemotherapeutic and targeted chemotherapeutic drugs. Everolimus and sunitinib, other drugs which are now part of the guidelines besides PRRT2. For small intestine and the small bowel nets, there are not too many options besides everolimus and PRRT on the guidelines.
True.
So this was a patient we had put in for discussion.
We'll wind up with this. You can tell about this case and we'll wind up with that.
Should we go back to the beginning of the case? So,
you want the previous one?
Yes, sir, the first one. So this was a metastatic grade 2 neuroendocrine tumor, Ki67 of 18%. And he was detected incidentally with hepatic metastasis and he was planned for a distal pancreatectomy and splenectomy. So this was the post-operative Dopaminergic scan which showed remnant disease in the liver. Now the guidelines, if we talk about the guidelines, there's obviously not much evidence in favor of surgical resection when there's a lot of metastatic burden, and this was also not entirely a cytoreductive surgery. But then with distal pancreatic lesions, the ENETs guidelines do have a statement saying, I think the surgeons can elaborate on this.
So I think we'll wind up our discussion at that. It's been an exhaustive discussion. I think the take-home message is that the prognosis generally varies with the grading of the NET. In high-grade NETs, grade 3 neuroendocrine carcinomas, chemotherapy definitely is an option. It should be considered first. For grade 1 and grade 2 cases, PRRT works very well. Currently, it's better to first exercise sandostatin as a first therapeutic option, followed by PRRT. If failed on lutetium, then consider actinium, and last but not the least, some ongoing clinical trials. So, Dr. Sugandha, you can just elaborate on these.
Yes, so we have ongoing trials where we are trying to establish the sequencing and more roles of PRRT fitting into the neuroendocrine tumor treatment regimes. There's a trial going on use of neoadjuvant PRRT. Some papers have already reported some very good progression-free survival advantage with neoadjuvant PRRT and upfront PRRT. Then there are trials going on with immunotherapy with or without combination of PRRT.
So this neoadjuvant PRRT setting is exactly the same that Dr. Gaikwad told us about.
About your case, if it's liver restricted disease, low grade tumor, there's a role of liver transplant as well for this patient. So that if they fit the criteria, he can be a candidate for transplant.
Excellent. Right. So thank you all of the panelists for the wonderful discussion.
Thank you, panelists. Thank you, Dr. Nishikant. That was a very detailed discussion. Moving on to the next session. So we have a difficult cases discussion based on the Theranostics. We have a tumor board comprising of very eminent mentors from all the fields of oncology. I would like to invite the panelists. Dr. Rakesh Chopra. Dr. Rakesh Chopra needs no introduction. Everybody in the field of oncology knows him very well. He has contributed immensely to medical oncology and has been doing so since last 40-45 years. Dr. Professor C.S. Bal, Director, Head of Nuclear Medicine Department, All India Institutes, New Delhi. Dr. G.K. Jadhav, he is Senior Consultant, Chief Radiation Oncology, Indraprasth Apollo Hospitals, New Delhi. Dr. P.S. Chaudhary, Director, Nuclear Medicine, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Professor Sanjay Gambhir, he is the Professor, Head of the Department, Nuclear Medicine, Sanjay Gandhi Institute of Medical Sciences, Lucknow. Dr. Brigadier J.K. Bhagat, Director, Head of the Department, PET Imaging, Nuclear Medicine, Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Ishita Sen, Director, Head of Nuclear Medicine Department, PET-CT, Fortis Memorial Hospital, Gurugram. Dr. Professor Ashwini Sood, he is Professor, Nuclear Medicine, PGI, Chandigarh. To present the first case, next. I would like to invite Dr. Praveen Kundu. She is Director and Founder, RNM Imaging Therapy Research Center, Rohtak.
Hi, very good evening, everyone. Thank you, organizers, for this wonderful opportunity where we can learn from teachers again. So I'll be straight away starting this case because I don't want to miss the opportunity of learning from teachers. So this was a case where we gave lutetium PSMA therapy in a case of metastatic CA prostate. And patient had penile metastasis, and from the very beginning, patient was just having low PSA level. Patient presented initially, he's a 83-year-old gentleman, presented with urinary retention, few bouts of hematuria, and underwent TERP, diagnosed as prostate adenocarcinoma SNR type. Grade was 4+5, so high grade. Gleason score was 4+5 and put in high grade. Started with the normal treatment, which is like bicalatide, leuprolide, and underwent few cycles of docetaxel. During this period, he had partial response, and initially, in fact, during initial staging, he also had some metastatic pulmonary nodules. So the question is, PSA is normal throughout the course. Then around 1.5 years into the disease, patient came to us. Patient had already undergone all the docetaxel and ADT. So this was a PET CT. Sorry, sorry. So this was first PET CT with us. We gave these penile lesions were there. Some non-PSMA avid lung nodules were also there. We gave progression. Clinician was not very satisfied. So because penile metastasis without any other disease, but still we gave progression. He was started on abiraterone around 3 to 4 months into the disease. Again, we did PSMA PET CT. So now it is much more clearer because we have this PSMA avid increase in number as well as the size of pulmonary nodules and increase in these PSMA nodules. Patient was asymptomatic at this point of time. Patient, after we diagnosed, then he told like some palpation is there. We completed the workup for PSMA therapy, and with the local tumor board, we decided to go ahead with the lutetium PSMA. After 2 cycles of PSMA, lutetium PSMA, this was the response. Disease kind of vanished. The complete, even the penile lesions and the lung lesions. These are the 3 time point cross-sectional images for this patient. And as we can see, these prostatic lesions, these penile lesions, they have kind of vanished in after 2 cycles of PSMA therapy. It was going good. Patient didn't have any toxicity. Just grade 1 anemia was there even after 3 cycles of PSMA PET CT. Lutetium PSMA, sorry. So when we were planning for 4th cycle of PSMA, just a week before, patient had some fever and herpes reactivation. Before, even during that 2 months of follow-up, patient didn't have any grade 2, 3 toxicity in either anemia, TLC, platelet, everything was normal. At that point of time, patient had grade 2, 3 in anemia. So we decided to postpone at this point of time. So instead of going around 6 to 8 months, 6 to 8 weeks, we had to postpone it for 12 weeks. So that was the thing. So this is after 2 months of 4th cycle, we again did a monitoring PSMA PET CT, and as we can see, some lung nodules reappeared. So again, we discussed in our local tumor board, and because we didn't have any other marker apart from this, so do we have any markers which we can use, LDH or alkaline phosphatase? I couldn't find anything. So after this, we decided to go ahead with 1 more cycle of PSMA therapy in this patient. And here we were surprised, in fact, because this PSMA PET CT, nothing was there in brain, but there was some heterogeneous uptake after PSMA cycle. And we did SPECT, which showed some lesions, and MRI showed some very subcentimetric lesions in the bilateral hemispheres. Patient is still asymptomatic, even at this point of time. ECOG is 2, patient is worried about going into some local elections. That was his worry. He's eating well. So what next? What next? Palliation, should we go for more cycles of PSMA therapy? Should we go for RT, local RT in the brain? Should we add immunotherapy? So in this case, these are the main points which we faced, and the issue is Is there a specific criteria when patient has some viral infection or acute bacterial infection? Should we postpone the PSMA cycle, or we can go ahead with the like blood transfusion, with the prophylaxis blood transfusion, or any role of any markers? So I would like to sir, please let us. These are the like main points which we faced.
So the disease was well controlled with lutetium, and after trying the chemotherapy, and then it came again after infection. So what you are pointing towards is the reasons for that, what biomarkers can be used, and why like this waxing and waning phenomena, and how can we control it, if at all?
Yes.
So the point here is it's an indolent disease, so it's going to move. So how long we can keep it restricted? Yes, so we are doing a lot of follow-up, and based on that, myelosuppression is there. So chances of infection is always there. That is one moot point. So you did the right thing by restricting the treatment for a while. That's how it is done in any chemotherapy. Counts are low, or infection has come in.
TLC and platelet was the normal side. Just depend. It was patient's HB was maintaining around 10.5 to 11, 9.5 once, and during this period it went to 7.5. That's why we postponed. Postponed. Otherwise.
Right. And the other point is there aren't many biomarkers that I know of. Any new people would comment about the new lesions coming in and the amount of therapy. So recently, you know, the number of cycles, people are coming with evidence that you can increase as long as patient is stable. And I think the recent JNM has one such studies where 13 up to 13 cycles they have given without any myelosuppression or without any side effect. So it would be board's decision whether you want to wait and watch, when you want to give. Brain, you said some vague lesions, you know, are there definitely lesions?
I specifically asked radiologists because I was not able to see on PET CT, but there were lesions. Yes, sir.
The prostate cancer with pulmonary metastasis is very advanced disease. It's not mild or moderate disease. The most of the death occur in prostate cancer if there is a pulmonary metastasis. If there is visceral metastasis, it is intermediate. But pulmonary metastasis is the most bad prognostic factor.
You to start with, yes, sir.
Okay, that's so. One point, you go back to the slides, you can see initially the PSMA scan was showing negative, and you give abiraterone, and then become positive. That's what I was telling. If you give androgen deprivation therapy and anti-androgen therapy, the receptor expression become more. That's what I was telling in the before section. Now you can see the image.
Yeah.
So don't jump into the first PSMA scan. If you give anti-androgen therapy, the expression of the PSMA is better.
Increase.
So now the scan, which is very, very elegantly demonstrated that it was not showing, and you give treatment. We have another patient with neuroendocrine tumor, is a child of a endocrinologist. We did the Theranos scan. It is a neuroendocrine tumor. It was not showing at all. And he went for chemotherapy. After chemotherapy, came back. Now this head to toe, all the metastasis is seen on the Theranos scan. So it is, they go on behaving. Similarly, initially you might have very good neuroendocrine PSMA expression. Subsequently, they go neuroendocrine dedifferentiation. So that's a dedifferentiation to neuroendocrine tumor. So you may not be able to see that. So all these things, tumor biology doesn't read the DVTA. Tumor biology will change on with each individual. So you have to look into that. In this patient, is very clear-cut example where anti-androgen therapy is given, the patient become better.
Just in this case, to Dr. Bal, what would you have done instead of abiraterone? I mean, hindsight is wise, but what would you have done in this situation?
All these studies have now demonstrated if you give anti-androgen therapy or androgen deprivation therapy, your somatostatin, PSM expression is increased. That's why this is helping us to treat. More expression means better. Even the study shows more than, the therapy study says more than 15 or 20 is better. Even the vision trial more than 9.5, it is better. So the uptake will be very high. So your requirement of your dose delivery to the lesion will be very high.
So was it right to change to lutetium, or should she have continued with abiraterone in this?
No, here we are using abiraterone as an enhancing effect to the lutetium therapy. Earlier there was no question. In that case, where there is no receptor, even if you give the therapy, it is not going to go. It is going to the urine channel. So when you given the pulmonary meds are now clearly seen, even the penile is, which was earlier only focal, you can see the whole the length. So it is a good thing that sequencing in oncology is very, very essential than just jumping the queue, as Apta very eminently told. Don't jump the queue. That is what he advised. So you go on doing things which is particularly in endocrine oncology. You would give the endocrine therapy. If it fails, lutetium therapy or any radionuclide therapy is advised.
So should we go ahead with FDG PET CT in this case now, or like that will be of no use?
It doesn't help in FDG. You know that is pulmonary metastasis very bad. What you are going to? You are not going to reinvent the wheel.
Even
you know that is a bad prognostic factor. Even if you do FDG, how you are saying that it is already somebody is bad. What you are bad, you are going to.
No, for the next cycle, like should we go ahead with the next cycle?
No, in this case, before we go for the next cycle, let me submit and compliment you for a very nice case presentation.
Thank you, sir.
The brain metastasis which has come, I mean, that has to be addressed. So whole brain RT has to be given in this case. Otherwise, he will throw fit, and maybe after a few days he will be
personally,
secondly, I hope the renal function tests are being
they are normal,
taken
sir. Everything is in the.
And then next dose of the lutetium has to be addressed to the patient.
So one of the reasons why pulmonary metastasis is bad, when there is pulmonary metastasis, there will be microemboli, and the brain will be the second target site. And once brain gets, the survival life expectancy drops to only 6 months. So you have to give palliative.
So I think it's also important to define whether these are parenchymal meds or they are leptomeningeal meds. So they are parenchymal meds. And another factor which we have to take into consideration is that he's an 83-year-old gentleman with a ECOG PS2. So I mean, whatever therapy we do has to be done keeping all this in mind. Saying that, you have an 83-year-old gentleman with a poor performance status, with pulmonary and brain metastasis. I don't know how symptomatic he is from any of the lesions. So.
Okay.
No,
till now, patient is not
and
much
83
symptomatic.
is just a number.
You said ECOG 2.
Ma'am, patient movement is just like he is not able to go for very long walks, but he's moving around, he's reading newspapers,
So
he's
ECOG
watching TV,
1. Okay.
he's coming and discussing.
So he's okay, his performance status is okay.
He's doing,
so that I think now there is also data saying that you can re-challenge with lutetium PSMA. Now that there is a gap, and if you have taken care of the toxicity, there is a role of re-challenging with lutetium PSMA, especially in view of the fact that the metastatic disease still is expressing good PSMA.
That is very heartening actually, because
just a quick question: what is the penetration of lutetium in brain metastasis?
So that is what, like, sir, in this slide we are able to see these last images. These are the SPECT images when we gave. This is lutetium PSMA post-therapy cancer. And that's why this heterogeneous uptake was there in brain, which was not there in PET CT, because, and so, geez, sir.
Dr. Chopra asked you a very penetrating question and you tried to avoid it. I know what the students do.
No, sir, I'm saying, sir, are there some expressions?
I'll tell you here, again, he asked, do the lutetium PSMA cross the blood-brain barrier?
Yes,
Your answer should be no.
Sir,
when there
uptake is there,
metastasis,
sir.
it breaks the blood-brain barrier, it goes. That's the answer.
You see, the question is that because it's the brain which is your major issue here right now, so, and she said that you should re-challenge with lutetium. That was my question. Is it going to be effective or not for that? For the systemic part, agreed. But for the brain part, the question is the same. Because she's right that at 83, It's the cognitive functions which are going to be the most important thing. At 83, if you give him whole brain radiation, whatever the radiation people may say in this world, once you give them whole brain radiation, there's going to be a downward trend as far as the cognitive functions go. Question is, what is his life survival right now? If his life survival is more than 6 months, then you should give him whole brain radiation.
How do we decide that, sir? That is the basic question, because it's a family of doctors.
It's a toss of the coin.
No, I think you need to define the intent of treatment as well. When you said palliation, what are we palliating? The patient is not symptomatic.
Quality of life.
She has received so many cycles already of lutetium PSMA, already had myelosuppression.
No, because the patient didn't have any myelosuppression during any cycle, till 6 cycles. Anemia. Ma'am, during that viral episode, he had anemia after
from
6
11
weeks.
hemoglobin dropping to 7 and coming back to 9. I think half of Indian will be anemic.
Yeah, but I think you need, at this stage in point in treatment, you also need to define what is the intent. What are we trying to do? And
yes, totally.
whether
sir.
the treatment is going to make the patient more miserable.
That is what's the quality of life, because I was really worried when patient didn't have any complaints for these penile lesions and these vanished. So that is something good, because if it was increasing and it was the PSMA therapy was not working, then patient might have like very difficult kind of urinary symptoms. And we didn't have any, we have given RT. So at least that is very heartening. Patient is not symptomatic.
Probably
I don't know what to do next.
I think
Dr. Partha is asking a very penetrating question.
No,
Are you
I
going to
think
cure
if
the
we-
brain? Are you going to cure the brain? Brain mets?
No, sir. No, sir.
So then what you are going to achieve?
Yeah, I think we see the principle of oncology is you also have to decide when not to treat, rather than when to treat, when not to treat. That's also very important.
Okay, local RT is out, sir. So next is like therapy is
If the
all
patient
out,
becomes
so-
symptomatic,
can
treat
give
with
local RT in the form of
local
radio-
RT, steroids or whatever.
Okay, sir.
I think I would agree with Dr. Chaudhary. Had this patient had progressive bone metastasis which had become painful, there was still a cause for retreating him with lutetium, because, and especially if it was generalized and not localized to one area which could have been handled with palliative RT. But in a patient who's got brain and lung metastasis, who's already, you've given him 6 cycles of 5 cycles of lutetium PSMA therapy, who has had at least grade 1 toxicity, grade 1, grade 2 toxicity. Now, and 83, so
Yes, sir.
there's only so much.
Ma'am, do you have any in this case, like brain metastasis, have we seen any response after PSMA therapy in any patients, ma'am?
So I have treated under duress a couple of patients with brain metastasis.
Yeah.
See, prostate cancer, even with brain metastasis, they do survive for about 3, 4, 5 months.
Yeah.
You have to be really, because sometimes lutetium, see, blood-brain barrier may be breached in a metastatic lesion as such. I mean, you will not have an intact blood-brain barrier often with parenchymal metastasis. So lutetium does reach the brain metastasis.
Yes, it's going there.
And after that, there may be a lot of edema. You may end up creating a situation where you have to give the patient prolonged steroids. Patient lands up with edema, and you don't know. And it's like unlike radiation, we cannot stop the effect once you've given.
goes, yeah.
So it sometimes becomes very difficult. So it has to be taken, the whole picture has to be taken into consideration, and you have to see whether you're really doing any benefit to the patient, or are you just treating.
Yes, that is the intent, ma'am. That's what I really wanted to
I
find out.
think at the end of the day, you need to leave this patient alone. Let him earn his treatment wherever it is.
Okay, sir. Thank you.
I don't agree. The brain has to be addressed in this case because there are big lesions. You can't leave the
That's
brain
what,
alone.
in the form of SRT or something, stereotactic radiotherapy.
Whatever,
or something.
sir. Some radiation
Some
to
local
the
radiation,
brain.
need not be whole brain radiation, just a local radiation.
For the sake of- for
it
the
is
sake
out of my mind came whole brain, but then maybe local SRT or something has to be given, sir. Otherwise, tomorrow when the patient
Patient family is not very intent for brain RT. They have ruled out
may or
that.
may not be, you have to advise them because tomorrow they will sue you.
Sir, I have referred them to radiotherapist.
Most of the treatment will make him more miserable rather than curing him or say palliating him. So that's what I said. We always say, let him earn his treatment.
For the sake of argument, is there any role of weekly paclitaxel here for the brain lesions?
Sorry, sir.
Weekly paclitaxel?
Sir, I don't know, sir, whether that.
Huh?
Sir, docetaxel normally doesn't.
Docetaxel at 83, you have to be very careful because of its myelosuppression and septicemia and all that. But weekly paclitaxel.
Okay.
That's just something which, I mean, is something which can be thought of, because that's something which is going to penetrate here with the blood-brain barrier being breached.
Already because of metastasis.
Can I ask a question to Dr. Chopra, sir? This gentleman, if I go back on the history, an 83-year-old gentleman with penile metastasis, and he was with high volume prostate cancer, high risk prostate cancer, was treated with docetaxel as a first line. Would you?
First of all, I don't like docetaxel. Number two, at 83, I will never give it because the risk of septic. There is a group of medical oncologists in North India who use docetaxel right, left, and center, whatever the age, whatever the disease, whatever the indication. I don't touch docetaxel, and there's a group of people who are very strongly do not use docetaxel in North India. Let me make it clear for the audience here.
Just for my inquisitiveness, can we, instead of lutetium, use actinium in this case?
This is what I feel. Actinium could have been used.
Yeah, actinium 225, yeah. So there is no myelosuppression.
We have 50 patients where half of them were given lutetium failed and actinium, and they did, it's about 24 months. From 15 months, it increased the 24 months. So.
I have treated a lot of patients with actinium to begin with. Now, one of the issues with elderly patients is that there is a lot of salivary gland toxicity. In an elderly patient, it leads to other problems of oral candidiasis, patient not able to enjoy his food, not able to eat his food. So, while it does give us a good PFS, at 83 in a gentleman who is largely asymptomatic, who has probably some mets in the brain which may or may not be addressed by local RT or with some anti-epileptics and I would be a little averse to using actinium upfront. Lutetium is much more gentler. It does give you longer, probably actinium gives you a longer PFS, but lutetium also gives you a fair degree of control. It is definitely better tolerated than actinium, especially in an elderly person.
Actually, about this salivary gland toxicity issue is very, very controversial. It varies from 100% to 10%. So we don't know because the salivary toxicity is depending on the grade 1, grade 2, grade 3. As per the CTC-AE criteria, in grade 3, what we are talking is all grade 3, where the people will not able to chew, and if grade 1 and grade 2, they normal have life, they may take a food, suppose they want to take chapati, they can have a half glass of water, they have to wet their mouth and they take. So grade 1 and grade 3 is very common, but saying salivary toxicity that everybody will not able to eat is a very, very controversial statement.
Quality of life would go down from here onwards, whatever treatment you use. In 83-year-old gentleman, you consider metastasis in brain, whatever therapy you give, whatever our lutetium or what. So the balance of his quality, whatever gentleman is doing walking, so if you take that away, the load goes on to the family. So decision has to be taken. What quality of life would you give? You want to give RT, you want to give actinium. So you can't do much about it.
Yes,
that's
I'll
my
let
opinion.
you know the family, the complete discussion.
Probably my piece of advice will be, don't give any more lutetium PSMA, just give stereotactic radiotherapy to the brain and watch for the patient because his life is not more than 6 months. So you discuss all these facts with the family, and if they insist, okay, you push more lutetium, then that is their choice, not yours.
Okay,
the less toxic treatment, the better.
Yes, sir. Thank you, sir. Thank you so much, sir.
I want to make 2 points, nothing to do with this case, but just for the education of some of our younger colleagues. I have a patient of metastatic gastrinoma, and if you look at his liver, it's like chutney. There's metastases everywhere. He works 16 hours a day, and I treat him with curcumin and metformin and sandostatin LAR 30. With this treatment for the last 20 years, we've kept him going, and he's absolutely fine. He works 16 hours a day, over 80, and you can't imagine what quality of life he has, which is fantastic. The only time that I gave him sorafenib, he said, "Doctor, tu bhi nikal ja, aur ye goli bhi tu apne saath le ja, and never show me this tablet again." This was his impression of sorafenib when I gave it to him for a few days. But I'm just telling you that sometimes these treatments also work. And this has been vetted by one of the top people in neuroendocrine therapy from MD Anderson. So please, it's not just don't give up patients. There is a role for these kind of things in treatment of neuroendocrine tumors, especially low-grade neuroendocrine tumors.
Thank you so much, sir. Thank you, sir. Thank you, Dr. Praveen. That was a very good case. Our next presenter, Dr. Ankur Pruthi. He is Senior Consultant, Head of the Department, Manipal Hospitals, Dwarka.
So, very good evening, everyone, and good evening to all the mentors and teachers. And many thanks to Dr. Parveen. It was a very enlightening case and solved a lot of queries in the minds of people like us. So, straight away moving to the case, I hope it won't take long. So, this is a case of a 72-year-old male patient who is a follow-up case of adenocarcinoma prostate, Gleason score 4+4, and the patient was diagnosed in 2012. This patient underwent radical radiotherapy in 2012, and it was followed by injection Eligard and tablet bicalutamide. Patient was doing well till 2014 when on a bone scan some bone metastases were diagnosed. This patient underwent palliative radiotherapy then in L5S1 region and right sacroiliac joint, 30 grays in 10 fractions in 2014. And again the treatment was continued, hormonal treatment was continued, injection Eligard and tablet bicalutamide. Patient was also started briefly on injection zoledronic acid, but it was stopped because of derangement in the renal functions. Patient achieved a nadir serum PSA levels of 0.068 in 2016, and after that the PSA started to rise. But patient was followed up and continued on the same treatment, and in January 2020 PSA reached a level of 1.15. Then patient was started on enzalutamide, but the patient developed progressive disease. Then in 2021, patient was started on first chemotherapy, that is docetaxel, and patient responded very well. Patient underwent 11 cycles of docetaxel, and the treatment was well tolerated also, and the PSA level and radiographic response was also there. After that, I think post 11 cycles, they started on abiraterone 500 mg in December 2021, last year. Now recently the patient PSA started to rise again, and recently it was 7.6 nanogram per ml in May 2022, and in April it was 5.9. A PSMA scan was done recently in our department. It showed extensive skeletal lesions. They were all PSMA avid, and there were some avid supraclavicular lymph nodes and abdominal lymph nodes. So that's about the case, and now patient was given
few treatment lines. Means he initially was under the treatment with medical oncologist. They were giving him abiraterone 500 mg. So these were the options which were discussed with the patient. He was also sent to us for a opinion for lutetium PSMA therapy. So I think my first question should be to Dr. Chopra. Please, sir, can you please elaborate? Means what should be done for this patient now?
Just a quick question. Why did they stop the docetaxel?
That is, I don't know. Actually, they said that
the patient was doing very well with
yeah, patient was doing very well.
Why did they discontinue? Was it due to any toxicity, or was it just at random that they thought that they should now move to an oral drug?
Yes, I think they should. They thought that the PSA has reduced to a particular level, so they can continue with this androgen deprivation.
I've treated patients with docetaxel for 5 years.
Okay.
Without a problem.
Without
in a
toxicity.
75+ old patient from Hisar. And he tolerated it very well. I mean, just a question why they started. Second was with the abiraterone, was it with food or without food? What was the...
They now, I just, and this was after breakfast, they said. After breakfast, they had to take abiraterone, patient had
with a fatty meal and all that?
Yes, yes.
And was it with prednisolone or without prednisolone?
I think with prednisolone, sir.
With prednisolone. Okay. So obviously the abiraterone hasn't worked and you have to move on to something more. Now whether you go to cabazitaxel or whether you go to lutetium, it's a toss of the coin. I mean, you can give cabazitaxel, patient can have toxicity with that, or you can go straight away to lutetium. I mean, it's a question of whom the patient is with. If the patient is in the medical oncology, he's going to give cabazitaxel. If the patient goes to Dr. Bal, he's going to give lutetium.
No, generally, the decisions should be tumor board based.
So in the tumor board, you have to decide. Na? I mean, if you as a nuclear medicine person say, okay, look, I have a stronger viewpoint, I've got better data, I've got better, then they'll go by lutetium. But it's and then there are a lot of other factors, the cost factor, the toxicity factor, the patient's general condition. All those factors have to be taken into consideration, and then only would you be able to take a call on that. So that's what I would do.
I think this patient should be subjected to lutetium therapy because we have a therapy trial where the head-to-head comparison has been done with the lutetium versus cabazitaxel. And it has shown good results without much toxicity. And
you know, ASCO 2022, everybody's gone back with saying, give lutetium. Everybody. I mean, the ASCO 2022, one of the takeaway messages is, give lutetium. So in this kind of setting, so that is what is it. But then it's a question of, you have to take a lot of other considerations before you do that.
So why docetaxel cannot be started again, sir? The patient has responded earlier very well, and it is not a case of actually docetaxel failure.
It'll be drug resistance, but I think that before he stopped the docetaxel, he should have been a little more careful. Unless there's an indication. If there's an indication, if there's a toxicity, the patient doesn't tolerate docetaxel, there's a problem there, then it's different. But otherwise, with such a great response, why do you want to stop? You have to carry on, because there's no question of drug resistance here. You're doing well, there's no question, unless there's toxicity. I haven't seen the patient. But if there's no toxicity, you should have, I mean, he should have carried on. But putting it back again now, it's a difficult question. Okay. You know, I mean, you've given a chance for the cells to get resistance to docetaxel now. So whether it'll be as efficacious now as it was in the first time that you had given it, it's query.
So, Dr. Bal, can you please elaborate with this patient?
In the last meeting of ASCO, the people are so much impressed. They told even don't do PSMA scan, give each and everybody lutetium PSMA therapy. So they were so much impressed. So with the data and the publication and backed by a big pharma like Novartis, underquote and unquote.
So, Dr. Chaudhary, can means this patient be straight away taken for lutetium because
each dose of you know what is the cost of in US the dose of one lutetium PSMA $42,500, and they need 9 doses. So multiply karo, and you can know what is the amount of money involved. And prostate cancer is not like neuroendocrine tumor, where there will be hundreds and thousands of patients will be there, not like 1 or 2 or 5 patients. You can see the economics behind it.
You see, all said and done, ASCO is a pharmaceutical-driven organization. So you've got to take everything with a pinch of salt. And also check with the ESMO guidelines on this. Again, that is the main thing. So you've got to be very careful. You have to take a lot of considerations before you.
So, sir, can this patient be straight away taken for lutetium considering docetaxel failure has not been proven
What
yet?
will be the ECOG score in this patient?
This patient was doing well, means low PS.
Low ECOG, so between 0 to 1 or maybe maximum 2. So you have got all the parameters fine. He has been given all the, you have got 2 options, either re-challenge docetaxel or go for lutetium PSMA therapy depending on its affordability, availability and source.
I think if docetaxel was being used and it was doing good results, you can still re-challenge with docetaxel. But these days, as you said, the buzzword is lutetium. And so whether you jump the queue or straight away go for lutetium, which can again be done because it's already metastatic CRPC. So it can be done. And otherwise, go from the smaller to the higher. And we must also keep in mind the financial toxicity. That's also very important as long as the therapies and all are concerned. Docetaxel is very cheap. And if there is no toxicity, re-challenge and keep it for the next time. Or else do lutetium, keep docetaxel for next time. I think either way, the patient should do well.
Okay. My question to Ishita ma'am, is there any role of FDG PET CT scan in this case? Because the patient was showing very mild uptake on that PSMA scan. Can we go back to the slides?
No, I think you had pretty good uptake.
Miss, I had one means previous scan also. That time the uptake was quite high. That was pre-docetaxel. But the post-docetaxel means though the fused images are showing increased uptake, but means any role of FDG should be considered.
I mean, I don't think doing an FDG really changes management in any case. I mean, if you get good uptake of PSMA and supposing you do get some FDG uptake, you would still go ahead and treat that patient. So for maybe as a theoretical
FDG will probably only prognosticate.
Yeah,
it will
exactly.
not help in your decision making with this PSMA avidity. So even if it is FDG avid, you are prognosticating that this patient may be not doing well in the long run.
Not going to do as well as another patient who has a PSMA, has a FDG negative scan. But yeah, so, but otherwise, routinely, if you get a PSMA uptake like this, I really don't see any advantage of doing another FDG PET scan.
See, after the therapy trial, where they did FDG scans also as a part of the trial, there is a lot of temptation in such type of cases to do an FDG. But again, believe me, FDG is only going to prognosticate, and it's not going to say that which treatment you should go for, because if you are looking at PSMA treatment, these uptakes are good enough to have a good outcome and expected good outcome.
There are some...
I would like to make a comment. The liver uptake is quite high. Do you feel it is F18?
Yes, sir, it is F18 PSMA scan. It is F18.
Right? you can see the gallbladder and you can see that.
We by now have evolved to see that what cases in such settings should go for FDG PET CT.
Yes.
So if we see the lesions, on the PSMA PET, whether it is F18 or gallium, if we don't see the lesions on PSMA and see on the CT scan, probably those are the candidates will go for FDG PET. So please keep in these things in mind. Not every case going for PSMA and FDG. There has been so many studies by now which defines that which case should go for FDG and which case we should stop at PSMA.
I think if you suspect liver lesions, triple phase CT would be the best option.
Because many a times we have seen liver lesions, PSMA, non-avid PSMA.
Yeah, so I think if you have liver lesions especially which are non-PSMA avid, you should biopsy them to exclude that there is no neuroendocrine transformation, because that is usually or small cell transformation, because that's usually the way the patients with neuroendocrine who have it's all about clonality. If the neuroendocrine component or the small cell component is dominant, so once you treat often we see this when we treat patients with lutetium PSMA, so first, second cycle patient's PSA goes down, and then suddenly on the third cycle patient lands up with extensive liver metastasis. So by that time the
last time when a leading mob was killed by the Britishers is Lala Lajpat Rai. Tell me 1919 and today, how many politicians has been killed when they are leading a mob? Never, because they will sit at home and will direct their chelas to do this. That's what happened when you give the therapy, the simple guys will be killed. The naughty ones will further mutate, the mutation landscape will change, they will pile up more and more mutation, more double DNA changes, there will be more non-homologous joining and more mutations. That's how they die.
That's a nice analogy to end this. Thank you, sir. Thank you, panel. Thank you, mentors. I think I am done.
Thank you, Dr. Ankur. We invite the next presenter, Dr. Kanishk. Dr. Kanishk is a senior resident, Department of Nuclear Medicine, SGPGI, Lucknow.
Thank you, ma'am, for the introduction. Hello. Good evening, respected teachers, mentors. I'll be presenting my case on a lutetium-177 PSMA 617 RLT patient that we were treating at our center at SGPGIMS Lucknow, in which HOD sir, our Gambhir sir is HOD. So we'll start with that. The patient, Mr. XY, is a 74-year-old gentleman. He is a known case of carcinoma prostate. Histopathologic examination done in November 2019 was suggestive of adenocarcinoma with a Gleason score of 4+4. The patient was on injection palmorelin, a 3-monthly interval, and the patient took docetaxel chemotherapy of 3 cycles, which last was taken on 17th of January 2020. After that, the patient presented to us for the baseline gallium PSMA scan, which was done on 28th of October 2020. At that time, as we can see, this is the baseline, and there are multiple lesions present, starting from the vertebrae and the iliac, as well as different other vertebrae and the humerus. Mostly skeletal lesions. Going forward, the baseline PSA level at the time of the scan was 4.29 nanogram per ml. So from here, the patient was having a visual analog scale of 8 grade of pain, and as well as going to the Eastern Cooperative Oncological Group performance status, the patient was having performance status 3, which was he was only capable of only limited self-care and was bedridden more than 50% of the waking hours. Going towards starting with the lutetium-177 PSMA radioligand therapy, patient was given 150 millicurie per cycle. Will be cycling through the planar gamma camera images, and as we can see, starting with the first therapy, which was given on the 17th of December 2020, and going towards the second therapy, which was given on 18th of February 2021, we can see a significant difference in the status of the disease, with only one solitary bone lesion present in the right iliac bone. Now, we went ahead with third and fourth cycle as well, and as you can see, only one foci of lesion was present on the post-therapy lutetium PSMA scan. Now, the spexity was taken on the fourth post-therapy scan, and we can see the solitary foci on the spexity in all the coronal, sagittal and transaxial images. After the 4 cycles of lutetium 177 PSMA radioligand therapy, the serum PSA level was recorded as 0.01 nanogram per ml. That was recorded on September of 2021. Now, after 4 cycles of gallium-68 PSMA scan, post 4 cycles, we did a gallium-68 PSMA scan, and it was as follows. So only the red arrow here, it is showing the solitary foci of uptake. So, so from here my dilemma starts. This is the crossed fused images of PET and CT, and you can see the solitary foci with a weak uptake. So the scan report was given as focal area of faint tracer avidity noted in right iliac blade, and as compared to the previous PET CT, it was a near complete response to therapy. Now, patient complained of mild discomfort in right iliac region corresponding to the site of uptake as seen in the gallium-68 PSMA PET CT scan. The pain score was 1 on the visual analog scale, and the performance status of the patient has improved to performance status 1. So, dear panel members, I would like to come to you for help that what should be done next, as we can see a solitary foci of PSMA avidity, and how should we proceed?
I have little bit of difference of opinion. Some patients, they are having exceptional response. Like this patient with single therapy, the patient almost all gone except one lesion that persists rest of the time.
Yes, sir.
So after this exceptional response, there was choice, either should give another dose, or you can go for only targeted treatment to the, so you can give external beam radiotherapy to that place and stop the treatment and keep the lutetium PSMA therapy reserved for future. If you adjust all the treatment then, and that single focus is not going to, even after that you give 3 cycles, that remain persistent.
Yes, sir.
So that's why, and we are not going to treat the PSA value.
Yes,
we
sir.
are treating the human being,
Yes,
and
sir.
got a solitary lesion, and that's to pelvic side. You can easily give external beam radiotherapy and
Yes, sir.
control that disease. That's what is my opinion.
Yes, sir. Thank you for the opinion, sir. Anybody is having another?
I second your opinion, sir. In such cases, it is better to preserve the therapy for further, you can say, progress time, whereas the solitary lesion could have been easily treated with the brachytherapy. Very nice.
I have a question.
But
for
if
you.
the patient is asymptomatic in that area, what is radiotherapy going to add? Pain is there?
Pain is, slight pain is there, sir.
Oh, okay.
Pain is at a level, slight mild discomfort is complained by the patient, sir.
Okay. There is pain, yes. Then
Even if there is no pain, sir, even if he is asymptomatic from that particular part, the disease is there. The disease has to be addressed, and we are addressing it with the
see,
radiotherapy.
how long can you chase a disease? You need to stop somewhere.
Solitary lesion. It is a solitary lesion.
Solitary disease, but if there has
Solitary
disease,
lesion
if
we
the patient
should
is
chase.
symptomatic, yes.
Oligometastasis has to be addressed, sir. 3 to 4 metastases
I
are
agree with
addressed
this.
these days.
I agree with you. Not only giving local radiation, but also add up zoledric acid to help in rebuilding.
A quick question. Why was this patient given Goserlin with docetaxel as an initiation? No anti-androgen therapy? I mean, unless prostate cancer management has changed, maybe we are old and, fuddy-duddies, but I haven't seen, I don't know why they should, the sequence should
Patient presented to us as such, sir. So from there, our
The answer to Dr. Chopra is that it is real world situation. We don't follow, we read only guidelines when we want to defend our friends. But for us, it doesn't matter.
So if everybody is agreeing on that, we should go ahead with the external beam radiotherapy. I'm glad. See, this is the tumor board discussion that we have gone through, and since what we have decided was that we'll do a gallium-68 PSMA PET CT scan at 3 monthly interval. That will be the follow-up, and these are the scenarios that we have come up with, and to treat the scenarios as such. If the SUV max of the current lesion increases further, then we'll go ahead with the radiotherapy. If the SUV max remains...
In that case, I will not do a PSMA scan. I will just do PSA, serial monitoring, and see what is the PSA threshold and how it is the doubling time. On that basis, you can know the disease. You don't have to chase every time doing a, because it's available with us, so you can't do the test.
No, but here, whatever we discussed, the tumor board decision doesn't match. It says if SUV max increases, then only you give radiotherapy.
How many people use PSA doubling time to follow patients? Ask the audience.
This is an open question as from Dr. Chopra.
My question is, how many people today use the PSA doubling time to make a treatment decision change or a treatment decision? Anybody? Is everybody ready for dinner?
Sir, I think we do in selected cases, not all.
And with a low PSA level like 0.1, and even before 2 PSA, your reproducibility of your Theranostics PSA to PSMA scan is not very high. So that's why it is better to go for the PSA, serial PSA monitoring, and then you feel that disease as our patient is symptomatic in that site, you can do a radiology X-ray, even CT, and you can treat the patient. You can start, that is the time when you should do it.
PSMA scan is needed after 3 months whether to see if there are new lesions. If there are new lesions, then we will go for the further PSMA.
Your PSMA scan positive, your PSA will rise. PSA is a biomic. Why we in thyroid cancer we always do a TG? Because we know that when the disease is coming back. Because biochemical markers are always in ahead of time, precedes the radiological changes. That is this is called basics of medicine. We should not forget because we are going tubular visions.
Okay, agree, sir.
See, I think we always do. It all depends where the patient is. If it's with us, we tend to do PSMA. But I think that's not the right way. We have to go from down to up, and that's where the role of tumor board comes in. No, so it's very, very imperative. It's never my patient or his patient. It's always our patient.
So this can be one of the key takeaways from this, that we should probably go ahead with the PSA level monitoring. So as I was discussing, if the what we discussed in our tumor board, if the SUV max of the current lesion increases, we'll go ahead with the radiotherapy. If the SUV max remains stable, we'll follow up the patient with 3 monthly scans or PSA level. Or if the new lesion appears, then we'll go ahead and continue with the lutetium-177 therapy. As we continued with the follow-up, patient continued to receive the zoledronic acid at 4 milligram monthly intervals, and injection palmorelin was continued to be given.
I would use zoledronic acid 3 monthly, not monthly. Monthly for 6 months and then 3 monthly. You can use it for 3.
Okay. Thank you for the input, sir. The patient came for the 3 monthly checkup and follow-up with the gallium-68 PSA PET CT scan. The serum PSA at this level was 1.74. Patient complained of increase in intensity of the pain in the right iliac region. The visual analog scale score has gone up to 6 now, and the performance status of the patient remained at 1. So this, we are comparing the last PET CT scan with the new PET CT that was done on 25th of February 2022. And as we can see, there is an increase in the SUV max of the increase in the uptake of the lesion. As there was increase in SUV max of the lesion from 2.3 initially to 7.8. Yes. Progressive disease. So we have gone ahead giving the patient, we have sent the patient to radiotherapy for solitary right iliac bone lesion, and this is the summary of the PSA value of the patient. As we can see, the patient is currently at PSA level of 0.05, and patient is currently healthy and pain-free. The ECOG status of the patient is at 1. The serum PSA level is at 0.05, and the visual analog scale score is at 1. So, does the company want to add anything further? Thank you. Thank you. Special thanks to sir.
We have our last case for today, Dr. Piyush Agarwal. He's also currently pursuing his MD nuclear medicine from PGI.
So good evening everyone. My case is on a 38-year-old female who presented to us on 5th July 2021 with complaints of upper abdominal pain for 2 months which had an insidious onset and it was intermittent. It was not associated with any jaundice, vomiting, diarrhea or flushing, and a CECT conducted outside showed a retroperitoneal mass in relation to the pancreas which was infiltrating the splenoportal confluence and with multiple collaterals and liver as well. So the patient underwent a US-guided FNA from the pancreatic lesion from outside, which suggested neuroendocrine tumor. On immunohistochemistry, the Ki67 was low, it was not mentioned, and it was synaptophysin and vimentin positive. A slide review was done at PGI and it was found out to be grade 1 with a Ki67 of less than 2%. The patient underwent both gallium dotanoc PET-CT and F18 FDG PET-CT according to the institutional protocol. And we can see a large focus of tracer uptake in the midline upper abdomen, which corresponds to the pancreatic lesion, and multiple foci of tracer uptake in the right upper abdomen, which on fused PET-CT, axial fused PET-CT images. The first is the F18 FDG PET. It shows a intensely tracer-avid pancreatic body mass along with a few liver lesions, and we can see the SUV max on the dotanoc PET was much higher than the FDG PET, which was 134 as compared to 45. It was a large mass of about 8.4 cross 7.5 into 8.2 centimeter, causing a luminal narrowing at the pylorus and having loss of fat planes with the splenic and portal veins. Additionally, there were multiple liver as well also present, and in all those liver lesions, the dotanoc uptake was much more than the FDG uptake. So the overall impression was the SSTR expressing pancreatic lesion with extensions, which was the primary, and SSTR expressing liver lesions, which were metastatic, and comparing with the FDG PET-CT, the overall net PET score was 2B. That means both were positive, but the SSTR uptake was much higher than the FDG PET. So seeing such high FDG uptake, the patient underwent a repeat F18 FDG PET-CT guided biopsy at our PET center, and the result was same, that it was a well differentiated grade 1 NET with a Ki67 of less than 2%. The patient was planned subsequently for a lutetium dotatate PRRT along with 1250 milligram per meter square capecitabine. The baseline values were almost normal except grade 1 anemia, and the patient had ECOG score of 1. So the patient was initially given 2 cycles of lutetium dotatate, and we can see the first post 1 cycle post therapy scan, the whole body anterior and the posterior images. After that, the interim dotanoc PET reported stable disease. The patient underwent another 2 cycles of this combination therapy, and the end of treatment PET also showed stable disease. Post this, the patient was on 30 milligram octreotide injection IM monthly for 6 months. So the PET-CT which was conducted after 6 injections of octreotide, these are the maximum intensity projection images of the serial dotanoc PET-CT. The first one is the baseline scan. This is the second one is after 4 cycles of PRRT, and these are almost similar. So it was a stable disease, but we can see after 6 injections of octreotide, there is significant decrease in the tracer uptake in the liver as well, and there was a partial molecular response, and but the disease was stable on according to the RECIST criteria, RECIST 1.1. So first, we would like to know that can PRRT be considered as first line treatment in this as in this case, or it should be considered as a second line as the recommendation. So what is the?
I think I was discussing with Dr. Chopra that these patients should have been given even LAR, sandostatin LAR 30, or even now people are giving 60 milligram. Waited for, because this anyway after giving lutetium you give this same thing, stable disease, you are going to achieve such a 8 centimeter tumor, you don't expect you get a cure. So in that case either it will be partial response or stable disease at best you can get. So you can buy time, and Ki67 is less than 2%, so it's a grade 1 tumor, just give 60 milligram or 30 milligram, or if patient can afford you can give 60 milligram sandostatin LAR monthly basis, continue the life as it is, and whenever required, you can go shift to the, if there is any progression of disease, then you can go to lutetium. That is more rational, because you have, I have a knife, that doesn't mean I can go and hit everybody.
Okay. Sir, we actually do not have a tumor board. We are not.
It was, sir, I just would like to comment. It was discussed with the surgeon and the medical oncologist, but being because of the avidity was high in the gallium dotatate scan, so we thought of giving that lutetium as a first, rather than actinium, rather than the sandostatin injections.
No, here there is a contradictory finding. Your FDG and SOJ uptake, your gallium SOJ uptake, gallium dotatate SOJ uptake, and the Ki67 is low, which is a biological marker. Your imaging marker is inferior to the biological marker. The biological markers are always superior than the imaging markers. So the biological marker here is the Ki67. So the cells are not dividing. If the cells are not dividing, doubling time will be 3 years, 4 years. So it's very long. So there is no fracture. You are trying to fix it and say, I have got the X-ray before and after. I have the best orthopedic surgeon in the town. Just like that. Yeah. You in this disease, what's your expectation? That it will be cured by your therapy? It will not. Because the patient has already FDG avidity, as well as the patient will have a longer time, and it will be slowly growing, because the Ki67 is less than 2%.
One thing, but when we do this thing, Ki67, it is from the one lesion. But we do have a heterogeneity of tumor.
Yeah, you did 2 times and you found the same finding.
Yeah, and you did it from a lesion which was FDG avid.
Yeah.
So yeah, but I mean, even on avidity, you've taken the worst case scenario in that whole heterogeneous too, and still getting a Ki67 of less than 2%. So
it's right from beginning, it's been detected with, symptoms were there, flushing, diarrhea, and all those were there. So you had to give LARS. And after that, there is no great evidence of it being, a progressive disease. You said, now after interim you did, and then you said it's stable. So as it is, apart from the clinical problems, it's like a stable disease. So you can give LARS and then just follow it up, and then take your time in making the decision. If the disease progresses, then you go for the therapy with lutetium. That's my
intent to treat is a very important point which we have to incorporate in our decisions of treating. Because, I mean, as Dr. Bal says, if you have a hammer, everything is a nail. So, I mean, you have to have the proper intent to treat.
It's very important to know what you are expecting before you decide on any treatment. So again, see, these intent to treat and all these are oncologists' words, which we have adapted, and I think we should.
Anyone who treats a cancer patient is oncologist. It is not it is the domain of medical oncologist only understand the cancer, and the radiotherapist only understand the cancer. Anybody who deals with cancer has to know the basics of cancer biology and the treatment protocols, guidelines, what is the recommendation, what is your expectation, what is your ECOG scoring, and how much you are going to be benefited, and the first principle of medicine, do no harm to the patient.
And the next nomenclature which is to come in is nuclear oncologists, which is is on the way. So that's again. So as Chandrasekhar says, oncologist. So it's a nuclear oncologist, also an oncologist.
A lot of thought process needs to be going in the decision making. The initial planning is most critical, and you've got to take all the parameters and then take a judicious decision. Because here you've got to string along this patient. जितने साल निकाल दो उतना अच्छा है. और अगर आप सब कुछ पहले ही यूज कर लोगे तो बाद में कुछ भी नहीं रह जाएगा.
Do you think when Karna came to the fight on the 11th day, he had also the weapon to kill the Arjuna, but he didn't? You know that? He has to use it for
The future of oncology is nuclear medicine. Please remember that.
Sir, the next question is, should patients with grade 1 NET also undergo FDG PET, generally it is recommended in cases of grade 3 neuroendocrine carcinoma? Or
the Italian group wanted to put both the scan, dual scan, double scan. Some of our Indian colleagues also presented. It has not achieved anything. The answer is there.
Okay. Sir, in terms of treatment response like to PRRT, does it have any prognostic significance, or whether deciding to give capecitabine as a radio?
No, see, we always put up a case which is anecdotal. That doesn't mean that all grade 1 neuroendocrine tumors should go for FDG. No.
I think FDG scan does not really change. If you have a Dopaminergic avid lesion, doing an FDG scan does not change your decision in any way. You would add capecitabine if the patient has got a grade 2 Ki67, which is slightly higher. In a patient who's got a Ki67 of less than 2%, I would not probably add capecitabine as a PRRT.
1250 milligram, and Dr. Chopra will correct me. The normal dose of capecitabine is 2 grams per square meter square body surface area. When you are only using 1250 gram, it is only for 2 weeks. It is only radiosensitizing effect. It has nothing to do with the cell number killing and others.
Your main drug is your Sandostatin LAR-30. That's the main drug, whether 30, 60, whatever you want to give, but that's the mainstay of your treatment. And that's what is going to keep you going for a long time.
And sir, is RECIST 1.1 the appropriate criteria to judge response in such cases, as we have seen that even if there is partial molecular response?
We tried to do PERSIST, it doesn't work. And we have no other option, but radiologists have got RECIST 1.1, because all the FDA trial, EMA trial, they need some sort of measurement. And Lord Kelvin told, in science, if you don't have the number, it is not science. So that's why we have generated some numbers. And that number is really translated to the effect or not, that is again controversial. Now they are talking about R-RECIST, radiological RECIST. Then RECIST 1.1 is RECIST itself. Why you are putting R-RECIST?
You know, we were involved in the planning for the RECIST trial. I mean, the RECIST criteria. Elizabeth Eisenhower and us, we all sat around. She's from Canada, from Princess Margaret, and we sat down and tried to make this RECIST criteria. And neuroendocrine was one of the most difficult place to put it into RECIST criteria. So there's always been this gray area, this controversy. So.
See, I would be very happy in treating a patient who is symptomatic to begin with, because then you have a marker. If the patient's symptom disappears, you know that you have done your job. Irrespective of whether your lesion shrinks, you have a partial molecular response, subpartial molecular, whatever. But if you have an asymptomatic patient, which are non-functioning NETs, they are a little difficult to, judge the response. So then we have to resort to all RECIST, iRECIST, PERSIST, and other things. But I think you need to, again, see the patient as a whole in totality, and the quality of life, if at all it's there. It's a multifactorial. It's not only one factor. To write a report, yes, partial molecular response sounds very good.
Thank you, sir.
Sir, one thing I would like to ask, if the FDG avidity is high, if the FDG avidity is high and all this thing, though they are not discordant, and one lesion has shown a grade 1 Ki67, do you feel capecitabine should be given in that case?
Capecitabine is not given as radiosensitizer you are giving, because what we are giving is 150 to 200 millicurie of the dose most of the places. But that is not MTD, that is not MTD. So nobody knows what will be. 300 millicurie is required, 400 millicurie required, 600 millicurie, nobody knows. So even if you give something, enhance it, that is the only the rationale. Otherwise, there is no study showing that 200 millicurie is the ideal dose. It is because it is done in trial, so we are following trial 200 millicurie. But where is the MTD, maximum tolerated dose? Nobody has calculated.
Thank you, sir.
I feel the key points in oncology still remains. We have to assess clinically, biochemically first rather than getting fixated with SUV. Thank you, mentors. Thank you very much. That was a very fruitful discussion.
Very rare combinations. सब आ जाएंगे अच्छी से फोटो लेना भाई सर आगे आओ आप पीछे मत जाओ एक फोटो ले ये ड्राइंग रूम में लगानी देती है
I would like to invite Dr. Swagat Das for the vote of thanks.
Thank you so much all. It was a great show. Thank you so much all the dignitaries, delegates, eminent moderators, esteemed panelists and all the participants out there. I really owe you all in making it a grand success. I would like to thank SNM India Northern Chapter office bearers, especially President Dr. Pankaj Duggal sir and Dr. Gaurav Mittal for all the guidance and valuable inputs. Obliged to all the sponsors without whom the conference of this magnitude was difficult to conceive. Special thanks to Safarios, our event and travel partner, to take out some of the burden out of me. My departmental staff, colleagues at Sarvodaya, thank you so much. You all are my strength. Dr. Jaspriya Bal and Dr. Bindhya Malasani, they need special mention for their excellent engagement skills. Esteemed doctors from other specialties like neurology, urology, radiology, oncology, I thank you, each one of you from my bottom of my heart. My family is my backbone. Thank you, Dr. Parul. My heart goes out to you. And last but not the least, it's Sarvodaya Hospital and its management, without whom this conference would have been executed so nicely and professionally. I am obliged to our chairman, sir, Dr. Rakesh Gupta, Group Medical Director, Dr. V.R. Gupta, and the entire management team. Our branding team did a fantastic job putting up a great show. Kudos to them. I would also like to thank all the support staff out here from Sarvodaya who are working tirelessly so that I don't get tired. Thank you so much all. Thank you so much for making it a grand success. Now I would like to invite Dr. Pankaj Duggal sir, current President, Society of Nuclear Medicine Northern Chapter. Dr. Pankaj Duggal, please come onto the stage, sir. Dr. Gaurav Mittal, Secretary SNMNC, onto the stage, sir.
So I think I need to give one special thanks to the management of Sarvodaya Healthcare to support or partner with SNM Northern Chapter And let's hope that with this initiative, now the next one starts happening the way it used to be in those olden days. So with that, thanks to everyone. And now we shall have our general body meeting. And one of the main agendas is to select or nominate the new members. I have been sitting on this chair because of COVID, and I have really grayed much more than I should have. So we will proceed with the GBM.
So the notification for next office bearers were circulated through email and WhatsApp, and we received few nominations. The nominations I am just elaborating. For President, we received Dr. Nalin Sinha, Artemis Hospital, Gurugram. Dr. Nalin Sinha. Dr. Nalin Sinha. And for Secretary, we received Dr. Nishikant Avinash Damle from AIMS, Delhi. For the post of Treasurer, Dr. Jiten Kapoor, House of Diagnostic, Yusuf Sarai, New Delhi. And for EC members, there are four vacancy in EC. We received Dr. Praveen Kundu, RNM Rohtak, Dr. Ashish Gambhir, Neurology Diagnostic Rohtak, and Dr. Manoj Gupta, Rajiv Gandhi Cancer Institute, New Delhi. So there is still one vacancy for EC as well. So I would like to now open it for the panel to decide. We have each one nomination for President, Secretary, Treasurer, and 3 out of 4 for EC. So it's open to discussion or any nomination. If anybody of you want to put yourself in. I'm thankful to, I'm obliged, ma'am, but I'm out of the nomination process. So, Dr. Duggal, sir.
I think enough emails were sent, enough messages were sent, and we should appreciate the people who took the effort to nominate some people. So I would tend to think that whoever has, whose names we already have, we should elect them. Yes. And whatever vacancies are remaining, those can be debated or people can be nominated here. I mean, of course, it's open to the general body to decide, but that's my proposal.
Any suggestion from the esteemed delegates?
What sir is also saying. We have the nominations, we can go ahead with that. Okay. There is one vacancy, we can debate on that.
There is one vacancy for EC member. If anybody want to self-nominate, if anybody, anyone on the spot. Dr. Markham, you want to nominate yourself? Many congratulations. So, Dr. Kanishk Markham, probably he will be the youngest in the next office bearers. So, I guess it's then final, sir. President, so I would like to announce the final results, if you permit, sir. President Dr. Nalin Sinha, may we have you, ma'am, on stage, please. Dr. Nalin Sinha. Secretary Dr. Nishikant Avinash Damle, may you have you, sir. Please. Treasurer Dr. Jiten Kapoor. Dr. Jiten Kapoor. And EC Dr. Praveen Kundu. Dr. Praveen Kundu, no. Dr. Ashish Gambhir. Dr. Ashish Gambhir, no. Dr. Manoj Gupta, may you have him, sir, on stage, please. Thank you. And Dr. Kanishk Markam. Kanishk Markam, thank you, buddy. Bouquet. Now I'd like to request Dr. Pankaj Duggal, sir, the outgoing president of SNMNC, to personally felicitate the new office bearers. Pankaj Duggal, sir. Dr. Nalin Sinha, ma'am, please. Many congratulations, ma'am. Dr. Nishikant Avinash Damle, Secretary, the new Secretary of SNMNC, Dr. Nishikant Avinash Damle. Dr. Jiten Kapoor, the new Treasurer. I have been the Treasurer since 2016 and I am really fed up. So I really wanted someone to take this up. Thank you so much. Then the EC members, Dr. Praveen, Dr. Ashish Gambhir, are you still there? Dr. Gambhir, please come. Dr. Gambhir, Ashish Gambhir, please come. Dr. Ashish Gambhir, the EC member, please. Sir, please felicitate. Many congratulations, Ashish. Dr. Manoj Gupta. Dr. Praveen has also come. Yes, Dr. Praveen, please onto the stage, please. Dr. Manoj Gupta. Many congratulations, sir. Dr. Praveen Kundu, the new EC member. We have, thank you so much. And the youngest one, Dr. Kanishk Markam from SGPGI. Many congratulations. So at least now, myself, Dr. Duggal sir and Dr. Gaurav Mittal, we can rest. Thank you so much. Thank you all. It was a great show. Thank you being part of this Theranos Conclave, and I hope you all got Theranosed. Thank you so much. Acha, Dr. Pankaj sir.
Not that we were not resting, we were resting for a very long time. But I think the biggest achievement was, of course, we did 3 meetings despite the COVID. Our biggest achievement was our Northern Chapter account was dormant for last several years, and we managed to activate that. So I'm actually carrying the checkbook with me. And not the checkbook.
It is to be handed over to the next treasurer.
Yes, I know. I'm not going to take it away.
No, sir.
Okay, so you should hand it over.
Yeah. Now the next treasurer, Dr. Jiten Kapoor sir, here is the checkbook.
I think we need to leave the stage.
Thank you so much, sir.